declare the meeting open to the public. Just to advise members, the committee meetings, as always, will be recorded and broadcast throughout Parliament buildings as well as online. Everybody in the public gallery are welcome to use mobile devices. They need to be in airplane mode and muted, and there's Wi-Fi details in the public gallery along with rules. It's not permitted to take photographs or any recordings of the meeting. Apologies? None? Okay, we have some members indicated they're going to join online. At Chair's business, there's none. Draft minutes, can I refer everybody to the draft minutes of the meeting held 19th of February? It's page 5. Everybody agree, or everybody content as they are drafted? Mm-hmm. Yep, thank you. Matters arising? None? Okay. So moving on then to item number 5, which is the SR 2026/16. This is the Health and Social Care Pension Scheme Member Contributions Amendment Regulations, NI 2026. So if you see at page 15 of the main pack, the details are there. So we have a clerk's memo at page 16, the SL1 is at page 18, the SR and the EM are at page 31, 34, and we also have correspondence from the department at page 38. So the committee noted the proposal for this statutory rule at our meeting on the 15th of January. We had a call for views on the proposed rule. This was issued on the 16th of January and closed on the 28th of January. We didn't receive any responses, and obviously no issues were identified. The committee considered the proposed rule at its meeting on the 5th of February and agreed that it was content with the policy merits of the proposal, also that we were content for the department to make the statutory rule. So the department have confirmed that there have been no changes to policy content since the SL1 was submitted to the committee. The examiner of statutory rules has also advised they have no issues to report on the rule. So can I ask members if we can formally agree that the Committee for Health has considered 2026/16, the Health and Social Care Pension Scheme Member Contributions Amendment Regulations, NI 2026, and has no objection to the rule? Content? Okay, thank you. Okay, item number 6 on our agenda is SL1, the Health and Personal Social Services, General Medical Services Contracts, Prescription of Drugs, etc. Amendment Regulations, NI 2026. This information starts at page 39 of our pack, and that includes a memo from the clerk at page 40, the SL1 at 42, and the proposed SR and EM at both page 48 and 50. Purpose of the proposed rule is to remove restrictions in the health and personal social care services, general medical services contracts, prescription of drugs, regulation NI 204, to allow flu antiviral drugs to be prescribed and dispensed by GPs outside of the flu season. So the statute rule will be subject to the negative resolution procedure. So members, can I ask that we note receipt of the SL1 and the proposed statutory rule, and that these will be published on the Assembly website and social media as part of our call for views on the proposal?
Great.
Thank you. Can I also ask that we agree that the SL1 will be scheduled for consideration at our meeting on the 26th of March?
Agreed.
Okay, so we have to consider whether we wish to be briefed by departmental officials on the proposed rule at that meeting on 26th. So, looks a pretty straightforward rule, but that's not to say members might want. So I'm open to yourself, so we can consider the rule with all the information given to us, and we can have departmental officials.
Could we have them there on call? Would that be okay?
Okay, just if we need them. Okay, thank you.
Just for questions, not to do any kind of briefing, just if we have any questions about it.
I mean, essentially the rule, currently there's a time frame for dispensing the flu vaccine. This removes that so that GPs can and others can prescribe it at different times of the year. So that's essentially what it says.
I ask, is there any knowledge about the time frame that you should dispense the vaccine? I mean, flu season is a particularly defined season. I mean, I'm not against it. Yeah. I'm just saying, like, why would you want to do that? Why would you want to?
I think one of the other ones is a flu treatment, of course, of
Yeah.
medications for
Right.
people with flu.
All right.
Yeah, so, sorry, I narrowed it down to the flu vaccine, but it's not. It might, I mean, I don't know if this is included, and I can ask, but I know, like, in some cases where you're flying to places in different time zones where, you know, so if you're flying from here to Australia, for example, and their flu season was, you may be able to get your vaccine here,
Yeah, fair enough. Yeah.
because I know that was the other way around.
Yeah, fair enough. Yeah. I
Sure,
hadn't
if you're
thought of
happy, I'll
that.
just a bit of what the department says about it. It says this enables HSE providing in line with provisions of further communications issued at the end of flu season when influenza levels have returned to baseline levels, which removes the ability to issue HSE prescriptions. Outside the flu season, when circulating levels of influenza are at baseline, GPs and NI cannot currently issue HSE prescriptions for its two particular drugs, Tamiflu and Relenza. While outbreaks of flu outside of flu season are relatively infrequent, the consequences can still be serious for vulnerable people, and the current restrictions can lead to delays in accessing necessary treatment with negative impact on patient outcomes, is what the department have said.
Sounds reasonable.
So anyway, we'll consider it in further detail at our meeting on 26th of March. So moving then on to item number 7, which is the oral briefing from Community Pharmacy NI. So can I refer members to papers at page 52 of the main pack? This includes including page 3 of our table papers. So we are going to So we're going to welcome Mr. Gerard Green, Chief Executive, Community Pharmacy NI, Mr. Nigel Kelly, Chairperson, Ethicum Limited, Dr. Turlough Hamill, Vice Chair of Community Pharmacy NI, and Ms. Marie Smith, Chair of CPNI and NI Regional Lead of BITS. So you're all very, very welcome before us. So we have received your presentation. I'm going to hand over to yourselves just if you have any additional introductory remarks, and then we'll go straight to questions and answers.
Thank you, Chair. Good afternoon, everybody, and thank you for the opportunity to update the committee on the issues facing the local community pharmacy network. I am joined here today, as the Chair has said, by Marie Smith, CPNI Chair, Turlough Hamill, CPNI Vice Chair, and Mr. Nigel Kelly from Ethicum Limited. Nigel is the Chairman of one of the GB-based wholesalers supplying medicines to pharmacies in Northern Ireland, and he has travelled from Scotland to be here today. He will share with you his own wholesaler experience in Northern Ireland, the difficulties he encounters, and where relevant, outline his engagement with the Department of Health. Firstly, I would like to say that CPNI recognises members' frustration with the conflicting views provided by the Department and CPNI. This is not the first time we've been at the committee. It's our third in 3 years. But today we want to bring clarity to issues discussed previously and also referred to in correspondence, particularly in the following 2 aspects. 1, whether community pharmacy owners are or are not struggling to pay medicine wholesaler bills. Secondly, whether the department negotiates the overarching community pharmacy contractual and funding arrangements with CPNI. I'll also touch on other aspects including clawback, the spiralling cost of generic medicines, and how that is compounding the £30 million funding deficit in our sector. I'll start with medicine supplies. In recent weeks, CPNI has advised the Health Minister and officials that medicine supply difficulties and drug reimbursement issues in Northern Ireland are presenting more challenges for pharmacies in Northern Ireland and also the public here compared to other parts of the UK. We met with the Health Minister on the 22nd of January, but to date the assurances and the actions that we recommended to the Health Minister have not been accepted. Be under no illusion that unless the Minister steps in urgently, the underfunding of the sector will be made worse to the extent that significant disruption of community pharmacy service provision, and most importantly, a critical disruption to the supply of medicines to patients in Northern Ireland will become apparent. The scale of the medicine shortages and the pricing issues are such that we have gone from shortages across about 100 lines per month, affecting 250,000 packs, to about 150 plus lines, affecting over 600,000 packs of medicines each month. This is additional workload and cost which increases our deficit. This further impacts on pharmacy owners' ability to pay medicine wholesalers and their overheads, and further risks medicine supply to patients in Northern Ireland. We have repeatedly raised concerns about pharmacies not being able to pay wholesalers. You will be aware that the department has downplayed any issues in Northern Ireland, saying to us that the wholesalers had not raised concerns in Northern Ireland or that issues are no worse than those across the UK. Many of you will have been contacted by local pharmacy owners, as have we. And let me be clear, pharmacy owners here are struggling to pay medicine wholesalers. From the feedback provided by community pharmacy owners, we are not reassured or convinced by statements made by the Minister and officials that medicine supply from wholesalers to pharmacies is not being adversely affected by the inability of community pharmacies here to honour wholesaler trading terms, i.e. pay their bills on time. Contractors have told us that neighbouring pharmacies are not receiving medicine deliveries from mainline wholesalers because accounts have been placed on stop, with medicine delivery to affected pharmacies only resuming when wholesaler accounts are paid. The collateral damage from systemic underfunding is that several medicine wholesalers have withdrawn from Northern Ireland or no longer supply pharmacies here. Why would suppliers stay in the market if they are not being paid in accordance with their trading terms and when the market is simply not viable? As it stands, Northern Ireland has the three main wholesalers, AAH, Alliance and Phoenix, and a number of shortliners, with Ethigen probably being the fourth largest medicine wholesaler supplying Northern Ireland. A number of second-tier wholesalers such as Sigma, Lexon, Colorama, DE, CrossPharma and Target have either withdrawn from Northern Ireland or exited the market totally. Fewer wholesalers mean less supplier choice, less medicine source, higher medicine costs and greater risk to the public. Wholesaler withdrawal should on its own be raising alarm bells at the highest level within the department. We are talking about the supply of medicines to local patients. The situation is sliding and further disruption could cause patient harm and have significant impact on the wider health system. You know that we have spoken previously about the community pharmacy funding deficit. We reiterate our position that there has been a recurrent annual deficit of approximately £30 million annually, and this goes back to the wrong funding level being set by officials in 2018-19 when there was no assembly. Despite the department's own cost of service report, published in 2017, which reported that the cost of providing community pharmacy services in the year 2011-12 was 136 million, officials inexplicably set the 2018-19 funding at £104 million. There was no negotiation at that time, and to be unequivocally clear, the department has not negotiated the overarching contractual and funding arrangements in Northern Ireland with CPNI since then or subsequently. As an aside, we noted last week in the Assembly that the Health Minister announced that he would be commencing negotiations with our GP colleagues for their arrangements for next year very shortly. We also want to take the opportunity here today to clarify some other points made by the Health Minister and the Department, whether that be in correspondence at the Health Committee or in Assembly asked questions. Many of you will have heard the Department talk about retained purchase profits, RPP, and how community pharmacy has made excessive levels of margin in recent years. Let me be clear again. RPP, as the Department refers to it, or the margin on the medicines dispensed, is not net profit. It is an essential part of the funding needed to pay operating costs in the pharmacy. The Department set that figure this year at £34 million. If we in Northern Ireland had the same percentage margin on the medicines as England, that figure would be £44 million rather than £34 million. The department has also claimed recently that recovery of so-called excess margin does not reoccur in Northern Ireland. The department claims that Northern Ireland, unlike other UK regions, does not reclaim any excess margin is incorrect. Excess margin is recovered in Northern Ireland because the drug tariff used here follows the same generic price reductions as England, which that tariff has the stated aim of recovering excess margin in England. By applying the same generic medicine prices in Northern Ireland therefore inherently recovers the so-called excess margin as well. I think many of you will have got representations from contractors, and so have we. I want to finish just with one sentiment that was expressed to us by a contractor. He said that the solutions outlined to the Health Minister, which we in CPNI echo, is to immediately remove the clawback mechanism. This is discount removal that harks back to 20 years ago when discounts were available in the supply of medicines. Quite obviously, this is no longer the case and clawback should be removed. This is the single most important decision you can make in the short term to create some degree of stabilisation. And the contractor then went on to say to the Minister, instruct your officials to engage and negotiate fully with CPNI about a new pharmacy contract. Imposing settlements and refusing to take on board the submissions and views of CPNI is not negotiation in his opinion. Thank you very much. I will now hand over to Nigel from Ethigen.
Good afternoon. My name is Nigel Kelly. I've been asked here to give you a bit of a window into wholesale and the payment issues that we are facing. My background is I worked in retail pharmacy for nearly 40 years, or I have worked in retail pharmacy since I qualified from Strathclyde University. Initially I worked at Boots before I became a pharmacy owner. I owned 9 pharmacies across the central belt of Scotland. I then founded Ethigen 25 years ago. Ethigen is a short line wholesaler based in East Kilbride. We've also got a depot in Bolton. We are one of the top 3 short line wholesalers in the UK by volume supplied. In terms of Northern Ireland, in the last 12 months we have supplied 455 pharmacies in Northern Ireland. This equates to just under £50 million worth of stock across 186,000 orders and 12.25 to 12.5 million packs of medicine in the last 12 months. To put that in context, there were 45 million items dispensed in the last 12 months, as per Professor Harrison's information that she gave you in the last meeting. I'd noted that Professor Harrison reported that full-line wholesale don't seem to be reporting any difficulties. However, one short liner has, and I have to assume that that's us. I feel that we're in a really unique position to comment due to our closeness to our customers, the personal relationships we've built with pharmacy owners over the last 25 years. Can I take just a quick moment to explain the difference between short-line wholesale and full-line wholesale? So Ethigen is a short-line wholesaler. We supply, I guess you could call it a limited range. We supply generic medicines, parallel imports, over-the-counter products, drinks and dressings. Full-line wholesalers also supply those products, but they also supply branded medicines. So you have to have an account with a full-line wholesaler to be able to fulfill all your prescriptions. So when you set up your business, the full-line wholesaler comes along and says, deal with us, we'll give you a discount on your medicines, pay us within 30 days and you'll get your discount. If you don't pay us within 30 days, your account goes in stop. So in essence, you probably don't really need to have a short-line wholesaler. But our job, I guess, for want of a better description, is we specialise in the generic and parallel import market. Our pricing is generally more competitive and we are more flexible, as I will go on to describe. Because branded medicines are essential, the pharmacy has to dispense them, the pharmacies will pay their full-line wholesalers on the date that they're supposed to. Otherwise, their accounts will go and stop, and they won't receive their discounts. Short-line wholesalers, like us, for example, are a bit more flexible, and we therefore get put closer to the bottom of the pile. We're a family business. We're very close to our customers. We talk to them a lot, and therefore we're in a kind of unique position to spot potential financial issues in pharmacy compared to full-line wholesale. There are other short-line wholesalers in supply Northern Ireland. However, we're the largest by a large margin. We are seeing our competitors moving out of the market. Lexon, Colorama, Sigma have exited the market. So my position is I would strongly disagree with the statement that we're not experiencing payment issues. And I did say this to Professor Harrison in an email in January. So we've been in communication with the department for a couple of years. And our message in the last couple of years, either in email or on calls, has been that we're experiencing payment issues. And so the last email I sent to them, I explained that the current situation, I'm afraid, is worse. Our accounts team are getting asked for extended credit on an almost daily basis, and we have more accounts in stock than we ever have before, including a large group. As you will know, Bestway and Lexon have pulled out of the market, and customers are looking to us to extend their credit limits. But that's an issue for us because we then can't get credit insurance on those extended limits. The narrative is extremely negative. Last year's business in Ireland were hit with not only minimum wage increases, but the national insurance costs as well. The feeling from our customers is that they're swimming against the tide, with some struggling to stay afloat. Many are saying they're having to dip into their savings to keep going. The narrative is extremely worrying for us. We're trying to support where we can, but we have to be pragmatic. Whilst we do have issues in other areas, Northern Ireland is certainly the worse than other areas. That was our email to the department. So from a wholesaler's point of view, let me just give you a bit more of a window. So I think in the last meeting you touched on credit insurance. So what we try to get for all our pharmacies that we deal with is credit insurance. Credit insurance is to allay the risk of non-payment. So credit insurers assess a customer's risk to decide whether to cover them for credit and at what limit. So they're basically asking the question, how likely is this customer to pay their invoices on time? They do this by analysing customer payment records and their accounts, if their accounts are online. We're finding it harder to get credit insurance in Northern Ireland over the last 2 years, and particularly worse this year. In essence, the credit insurers are saying to us that pharmacy customers in Northern Ireland are now a bigger risk than they were before. So then we have to assume that risk, and that's a commercial decision that we've got to make. I'll give you some stats. In the last month, out of 414 pharmacies that were due to pay their accounts at the start of the month, 47 paid in time. 367 pharmacies didn't pay their bill in time. We do have relationships going back 25 years, so we do take a pragmatic approach, and we're doing our best to support our customers. In the last 2 years, we've seen many more pharmacies asking for extended credit. My brother is the CFO of the business, and he's on first-name basis with lots of the pharmacies here because they're phoning up and talking to them about when they can pay. They might have to wait till the VAT return comes in. So this is things that we see that a full-line wholesaler won't see. The problem is the cost to carry that credit is going up for us every year, and it's me or my business that has to assume that. So I think there's 2 points that need to be considered. The first I'm calling the financial hole, and that hole would be there if we put every one of the 367 pharmacies in stop that are due to pay us at the start of the month and stop supplying them until they pay the bill. We don't know where that money's going to come from. If that was full-line wholesale, if we weren't in the market, that's what would happen. There'll be a large financial hole in the sector. it'll put a bigger strain on what we see as an already fragile market, and in our opinion could be the catalyst for pharmacy closures. Secondly, if the payment issue isn't brought under control, there's a risk that more suppliers, including ourselves, will exit the market. As we say, Colorama and Lexon have, and they're the biggest, including us in the UK. So we're the biggest that's left in the market. So what you're facing is a shortage of suppliers, not necessarily a shortage of medicine, but a shortage of suppliers. If you have a shortage of suppliers, the more suppliers you have, the more competition there is. If we're no longer supplying the market, the reduced competition will drive the prices up, directly affecting pharmacy margins. This will be reflected in the margin survey, and as a result, the overall drug bill in Northern Ireland will go up. Maintaining a diverse supplier base is essential to protect both pharmacy margins, public healthcare spend, and ultimately the supply of medicines to patients in Northern Ireland. I hope this has been helpful. Free to answer any questions you might have.
Okay, so thank you very much for that. You're right, you've been here quite a lot. We've heard a lot of these arguments before. You'll be aware after engagement in December we wrote to the Minister in relation to a number of these issues. I think we were quite vociferous that we wanted the Minister to engage with CPNI in terms of a negotiation with regard to Corfontaine. We got a response back to say that there's a difference of opinion, and I mean the Minister's got his opinion, and we're hearing a different opinion here. So it's I suppose in all of these scenarios, it's how we as a committee judge the two different scenarios that we're hearing. We asked him also about the Corfontaine or the negotiation, and he said that clawback and Fontaine was on the agenda and will be on the agenda next time. So I'm going to ask you about that. But from a health committee's point of view, because a lot of this is economics, it's business, it's from our point of view, or certainly from my point of view, I am concerned about how this kind of instability within community pharmacy actually impacts on health outcomes for the patients I represent. I've had a lot of contact from community pharmacies over the last couple of weeks. I want to thank the people who have engaged with a lot of them through email, through phone calls and in person, and some of them have opened up their books to explain this because it can be quite complicated. So I want to put on record my thanks to all the community pharmacies who have engaged with me over the last couple of weeks. So I mean, I just want to get to the bottom of this. So from at the end of this session, that we're a wee bit clear in terms of the two arguments and how we as a committee can help that process forward. So medicine supply issues, first of all. Can you maybe give us an example of the types of medicines that are in short supply, and how that's impacting patients, or how patients are having to do without, and the impact that might have, and what happens in scenarios where patients can't get their medicines because local pharmacists can't supply it.
Okay, the range I talked about there being upwards of 150 medicines, and I think that number is growing. I think you're aware from the press that we had a couple of weeks ago, we talked about common medicines such as cocodamol, aspirin, but this extends. I mean, aspirin is not just aspirin, the painkiller. This is used to prevent heart attacks and strokes, but it is the full gambit of medicines. It is cholesterol lowering medicines, it's antidepressants, it's antibiotics, it's blood pressure medicines, it's stomach medicines. It's blood pressure. There's some sleeping medicines. So the range, it covers everything. It reaches into all the different therapeutic categories. I think the issue is that we are really struggling. We have seen a surge in this over this last number of weeks and months. And what we're saying to the Minister is, you've got to recognise, you've got to get on top of this here, because patients in Northern Ireland will suffer. These medicines, patients are on them long term. They're used to treat long term conditions. And the reality of it is delays in the medication could affect the long-term condition management, and that then will have knock-on effects on patients possibly having to see the doctor to get reviewed. We know the pressures that are on GPs and potentially hospitals as well. So this has a real knock-on effect here. And
So can I just interrupt you there? So say I'm in one of these conditions and I need a particular medicine, and I go to my local pharmacist and he's saying I don't have that medicine. Is it the case then that the next one might have it, or is this medicine going to be in short supply right across the north?
These medicines, and I'm happy for any of the practitioners to jump in at any stage here, but these medicines are right across the board short at the minute and in short supply. So just going to the next pharmacy won't sort the problem out. To give you an example, believe it or not, our organisation was contacted by a lady recently to say that the medication that she uses for her glaucoma, she had 2 days of it left, and she was so worried because she couldn't get stock of it that, you know, her fear was going blind. So this is the real patient impact that these issues are having, and it's the distress, etc., on the way through. So this is real.
So you said the minister and the department need to get a grip on it. What is it they need to be doing?
What we are saying is, you know, the minister needs to, first of all, realise there is a growing major problem here with medicine supply into Northern Ireland. He has to, in the same way that it was done ahead of Brexit, done ahead of the pandemic, is try to secure additional stocks of medicines from whatever medicines are within the UK for Northern Ireland. We've heard that there are fewer wholesalers. We are at risk of just not having the access to the medicine. So we have said to the minister, you need to get in and link with your health minister colleagues across the UK to ensure that the public of Northern Ireland have access to the medicines. And then I think, you know, picking up on what Nigel said earlier, I thought the statistic of 367 people being late in their payment out of 414, that is quite chilling. That is quite chilling. That is a level of the destabilisation that there is within community pharmacy. And what you have whenever you do not pay your wholesalers, and I think Nigel's organisation is trying to work as best as it can, other wholesalers have exited the market, and you know there is a risk that the model is such that it has resulted in people exiting the market. The issue is that fewer wholesalers means that we have less access to the medicines, and we are struggling to pay wholesalers. That's come clear.
I want to interrogate that, but I just want to finish the issue of the drug supply, because in all of these scenarios there is two narratives. So I mean, I've wrote from my own perspective to the minister raising these issues, and I know that the committee has written. So the minister and the department are saying, you're telling us as people on the ground, there's an issue that's getting worse, and it could have potential negative, serious impacts for patients here in the north. And then, I'm not saying that the minister and the department are going to put words and say they're rather blasé about it, but they seem not to be concerned about it. So I'm just trying to, why are they not concerned? I know there was the issue of long.
What I will say is that I think this issue is recognised across the water as a major issue. The House of Lords commenced an inquiry last summer onto the supply of medicines in the UK, and they saw it as a national security. There are various mechanisms in place to try and manage shortages, and I think that's the default of the department, is we are part and parcel of the UK system of managing shortages. But within the report, the report findings that came out of the House of Lords within this last couple of weeks, it was scathing of the DHSC's handling of the supply of medicines. So to rely on the arrangements in England that have been criticised, this is why we're saying a more proactive approach needs to be taken by the department here in Northern Ireland. I think as well, so that there isn't the risk of people not receiving their medicines, they need to be able to pay their wholesalers on time. If there is that level of pharmacies not paying second tier wholesalers, that's going to trickle up into the mainline wholesalers. And this is where we have said that the funding within the sector is contributing to that, and there needs to be a relaxation of the clawback arrangements so that pharmacies can pay their bills and the risk of medicines not being withheld from the pharmacies is reduced.
So in terms of the wholesalers, and Nigel, I mean, I think we have to be very careful that, again, our conversation are on patient outcomes and the impact of supply, not too much on business, but on that side of it. But again, with regard to this issue, community pharmacy, and you're saying there's an issue here, and the department and the minister are telling us there isn't an issue. So I'm just wondering, have you had any engagement with our other wholesalers and yourself? Are you engaging with the department here? What kind of conversations are you having, and what's the outcome of those?
The email that I read out was my engagement with Professor Harrison and her team. We probably started talking a couple of years ago when we were asked about was payment gets any worse, and I said it wasn't great, slightly worse than the rest of the UK, but not great. But my email in January explained that it's got an awful lot worse, and the impact is, well, when you're talking about shortages, and this is quite a commercial point, but we're talking about aspirin being short in the market. So aspirin is used by millions of people on a daily basis. The product goes short, and I think where the minister's getting, I would say, mixed up is we can talk about branded medicines being short. Branded medicines are short. What then happens is the doctor might prescribe something else that's a similar product. If a generic medicine's short, the price goes up. Yeah. And the price can go up from £27 to £3 overnight. If the price goes up to £3 overnight, the pharmacist doesn't know if he's going to get paid £3 because the drug tariff price is 50p. So there is a mechanism to put that product onto concession, but the pharmacist won't know about it until they've bought it, until the end of the month. So you've got a pharmacy that's, I would say, some are teetering on the edge, and they're saying, well, should we really be buying this? Because I don't know if I'm going to be paying £3 for something and only getting 50p back for it. So that's where the shortages are really impacting. And there are, how many on concession? 160 products?
Yeah, there's at least 160.
160 products just now, accounting for 650,000 packs a month. So those are products that the pharmacies are dispensing. They don't know the price they're going to get paid for it. And that, no matter how you look at it, is unfair.
I've actually had a couple of pharmacists that explain that to me in detail in terms of what they're having to pay. And it seems it just doesn't seem like a particular good way for a business to run. Never mind a vital and important part of our health service. So in terms,
my point is we are engaging with it. With
so I mean, you mentioned a number of wholesalers that have pulled out of operating here in the north, and I mean that then I expect is because, I don't want to put words in your mouth. So, like, what kind of concerns, or why are wholesalers pulling out, and is there concerns of other wholesalers pulling out in terms of operating here?
Gerard said we're probably the part of the big four. There's 3 full-line wholesalers, and there's us. Why have the others pulled out? The cost to service Northern Ireland is more expensive than it is for me to service my customers in Scotland. So that's one thing. So I guess on an annual basis, you'll run your budgets and you look at your different areas and say, well, what's my cost to service Manchester? What's my cost to service Scotland? What's my cost to service Northern Ireland? The cost of service includes all your trunking and delivery and all the rest of it, but also is your credit insurance, the credit that you have to give to customers. And if you're unsure about people getting paid, then they'll move out. So one of the bigger companies that I know, the person who knows it quite well, and he just said he wasn't comfortable with the market. I don't obviously want to name who that person is, but they just weren't comfortable with the market.
So if wholesalers aren't, if they don't see this as a profitable market, they pull out, and that has an impact on medicine supply for our patients. Okay. So, I don't want to hog the meeting, but I want to get to some questions in relation to the funding issue, because that might well be the most important bit of the conversation. So, again, you come before us, we have this to and fro between the department, and, again, the minister's saying, well, I hear what you're saying, but I don't really believe what you're saying, or words to that effect. The department are saying time and time again, community pharmacy funding is increasing. And yet all of us are getting contacted by community pharmacists who are saying they're literally struggling. So why is what the department's saying about increased funding not having an impact on the ground?
Additional work. So fundamentally, the future direction of the profession, there isn't disagreement in the moving forwards towards that additionality, clinical model, service-based model, and so we don't want to come across that we're entirely negative about everything with the department. There are some areas that we agree on, and services and the progression and development of those and the enhancement of the clinical role of pharmacists, 100% we agree on. There's no issue with that. The additional funding that has come into the system has been geared towards that additional work. So in effect, it's the same as saying to a nurse, we've given you a pay rise, but you have to work a Saturday and Sunday now as well. It doesn't fundamentally underpin what they're paid as their base salary. And so that as our costs have gone up and our underlying core funding hasn't risen in line with costs and workload and volume and inflation over those number of years, that's where the issues have come from. And very often our interactions almost feel Orwellian, sort of the department, that we've been asked to reject the evidence of our eyes and our ears. That we have, Nigel is here and he's giving an opinion. I mean, look back at the meeting in December with the department, and that when discussing about supply chain exit from Northern Ireland, the department state that it's a commercial decision that companies make and it's beyond the department's control. There's nothing that they can do to change that. The department is the ultimate buyer of all the medicines, that unilaterally sets the prices for the medicines and unilaterally dictates the amount of margin within the system. No other person dictates the commercial viability of the supply to Northern Ireland, and it is solely departmental policy that creates the viability of supply to Northern Ireland and the viability of contractors to supply. And again, much as we've said before, the cost to service Northern Ireland is higher. It's just a commercial reality. It's not Brexit, it's not anything else. It's the fact that goods have to go on a boat, come across here, compared to just a hop on the road from London to Birmingham or wherever else that may be. And it's quite an English-centric supply chain model. And so the brittleness that comes with the supply chain, because you don't have the breadth of suppliers, is part of the issue that is generated, and the workload in managing some of that. And so where we talk about that retained margin, the core part of our funding that it contributes towards our staff or operating costs or rent or heat or rates, which aren't funded unlike others. And so that contractors manage £500 million of procurement, storage, distribution, management, absorbing losses from changes in prescribing habits if medicines are stocked out of dates, changes around all of that, that comes with a cost. And if you imagine that the amount of medicines over the past decade has increased in the ageing population and a multitude of factors, there's a cost associated with all of that, and it is a cost that the department don't acknowledge. And that's one of the key fundamental issues, and it's that core service that we deliver is what is at risk. And we may get to the point, and if we continue further down the road, we'll be able to deliver the services. Patients may not get their medicines. That is the challenge, because there has to be an acknowledgement. There's been increased volume, there's been increased workload, there's been increased complexity, increased costs, and the department's obligation is to pay us fairly and reasonably, in amongst that. And there isn't an acknowledgement that there's an issue. And whilst contractors will state it, supply chain stated it, it's been widely said, and we try to be as open and transparent as possible, and it'll obviously be for everyone to make their own judgment in terms of how they interpret the advice and guidance that has been given, but it's very, very, very challenging.
Chair, if I could just come in, because Gerard has already covered about the substantive deficit in the core funding, which is the safe supply of medicines to patients. And he covered it off, but I think it's important to restate the cost of service inquiry that took place. It was the department's cost of service inquiry to look at what it cost to provide community pharmacy services in Northern Ireland. In 11-12, that reported £130 to £136 million, and they set the funding in 18-19 at 104. So that is our 30 million deficit that we're talking about. And
so just explain that again. There was a cost of service review in 2011 that said that the cost for providing community pharmacy was 130 million.
130 to 136. There was within that
15
parameter.
years later, they're given 104 for that service.
2018-19, so it was the
7 or 8
years later, 104. So you're talking your 30 million deficit in that core provision. And, I would echo what Turlock has said in terms of the strategic direction of where we want community pharmacy to go in the delivery of more services to benefit patients. and really to utilise the skills of the community pharmacist. We've highly skilled, highly trained pharmacists coming out of university with independent prescribing qualifications that we absolutely want them to utilise. So the additional funding, we've never disagreed on that. We're keen to have that and to ensure that pharmacists can deliver those additional services to patients. It supports the shift left, it supports what we want to do, but we can't continue to do that when we have this core funding deficit that remains.
Just so that I'm clear, so you said about 2011 what they said the cost should be, and then you said 2018-19. What is it in 2025?
Well, we've had subsequent numbers that we built up on that
so the
number.
Opening allocation this year was £154 million. But in the intervening period, as Turlock and Marie have said, the range of services that have been introduced, and also then the annual DDRB uplifts, the NIC wages, the costs offset there, and we acknowledge the reduction in the or the removal of the clawback on appliances, just one element that has allowed the envelope to grow to that level, but it hasn't addressed the core funding, and that's where the issue is, and that's the bit that is now impacting on the likes of the wholesalers.
I just want to briefly talk on the clawback issue, because it seems a very archaic way of providing a service, and I mean, I know my own engagement with community pharmacy, that is the main bone of contention, where money's been stripped from community pharmacy based on something that might have been reasonable 15-20 years ago. So just if you can briefly describe the impact that is having on community pharmacy.
Okay, so in Northern Ireland last year there was something like £470 million worth of medicines procured by pharmacists. So that's what was dispensed. If we go back, say, 20 years, when pharmacies went to their wholesaler and said, I want to buy my drugs from you, that wholesaler said, I can give you a deal, I give you discount, you buy your drugs from me. So, for the sake of round figures, typically 10% might have been offered. So the chemist then got a reduction on the drugs bill through that wholesaler of 10%. Quite understandably, no issue with it at all. The department at the time would have said, well, hang on a minute here, we're not paying a full price for something that we know that the sector is getting 10% discount on. So we will reduce the payments by what is now known as the clawback. And that clawback was a percentage that reduced the payments. And that's fine. The issue in the intervening years is that the discounts being provided by the various wholesalers has disappeared to all intents and purposes, to the extent that last year, we anticipate the clawback this year will be £23 million, when probably the sector will only be able to achieve discounts of £3, possibly £4, £5 million.
Well, in instances, pharmacists are paying more for the drugs.
Yeah, and that's contributing to the funding deficit. We also haven't had many of our fees increased in probably 20 years, so there's actually been the impact of inflation there, so they need to be brought up as well. But the clawback is being taken at a level of approximately £23 million this year, whenever clearly the evidence would suggest that it's no more than £3 to £5 million. And
this system was in place in Scotland, and that was done away with.
Yeah, and this is why Marie talked about in 2018 when the envelope was set, there was no negotiation at that stage. It was just applied. So we had no right of appeal in essence, or any negotiation. And that's where our problems have just emanated from. And as there's supply problems in the intervening years, you get real pinch points, and we're in one of those real pinch points now.
Okay. And the last point, I say, the department, we have, as a committee, asked them to engage in proper negotiations with yourself to resolve this issue. They don't seem to be, but they have relented in a similar scenario with GPs.
Yeah.
I mean, how do you think that, or how do you intend to get them to engage with?
Well, we repeatedly ask, and we have it in various forms. Every correspondence in essence goes in with a plea to negotiate, because at the end of the day, as Turlock and Marie have said, we want to get on with the job of looking after our public that come into the pharmacy. We want to increase the services, but it needs to be based on the right level.
When the minister's writing to us and saying that core funding is on the agenda every time we meet you. I mean, what are the conversations?
It might just be, and I'm trying to be respectful to the Minister, it might be that's what we have in essence allocated, and that's the language that's used. The department allocates the funding out of available budgets, and that's how it is. That's the way it's portrayed to us.
But it's not a negotiation.
No, there's no negotiation. So to some extent, when we heard the comments in the Assembly last week or the week before about negotiating the GP arrangements, overall contractual funding arrangements for next year, we sort of think, as a critical part of the health service, doing a critical role for the public in Northern Ireland, and as Turlock says, managing a budget of £600 million, you would imagine that there would be some overarching agreement on the arrangements of how that would be played out, not a unidirectional and the unidirectional approach, unilateral approach, is now giving rise to all of these issues.
Okay, thank you. Danny?
Thank you, Chair. Thanks very much for coming in again. I think the fact that we've seen you so often shows just how serious an issue this is. And I know I've been contacted by local pharmacists similar to the Chair, and I'm sure other MLAs as well. And it's always the same issues that they're raising. I'll first just declare an interest as Chair of the All-Party Group on community pharmacy. And to highlight that we are in a situation where there is competing narratives here, and we are having a back and forth. There was a previous error by the department when they came to this committee, and I know that error was challenged by yourself, by CPNI, who came back with figures and were able to correct the department, and the department had to come back here and apologise to the committee for providing the wrong figures in relation to comparing the funding of Northern Ireland pharmacies with Scotland. So the department had got it quite wrong, to the tune of, I think,
100 million, I think it was.
Was it 100 million? Yeah. So quite a significant error there, but the department did come and they did apologise for that. Like other MLAs I have been contacted, I just want to read out a brief bit from a pharmacist in Cushendall, as his own guild in Cushendall, and he was saying that with escalating medicine shortages, I have growing concerns that patient care is being potentially compromised through delays, leading to increased clinical risk. And that's, that hit me very hard, that he's very concerned about his patients. Now, this is a pharmacist in a very rural area in the Glens of Antrim, very concerned about, the risk to his own patients. I know particularly, Nigel, we haven't really heard from the wholesalers previously, but it came up quite significantly in the last meeting in December. Now, in the last meeting in December, the department officials told the committee that they regularly engaged with wholesalers about concerns raised regarding pharmacies' ability to meet payment terms. Does that reflect your understanding of the situation? And you obviously have told us that you have had some involvement and some engagement with them. Are you aware of how those discussions are going with other wholesalers as well?
No, I'm not sure how they're going with other wholesalers. I guess if regularly means every year, then I guess we have probably spoken 3 times over 2 years.
3 times in 2 years?
Yep. The last time being in January.
And that was an email, or?
So I've had Zoom calls with Kathy and her team, and the last one was an email from Sean.
Do you think that's regular engagement? Do you feel that's regular engagement?
No. And I guess when I read that the report was that full-line wholesalers don't seem to be reporting any difficulties, however one short liner has, is it's disappointing, because I think that it doesn't really mirror our importance in the supply chain. And if we're reporting that we are seeing issues, and we're reporting it quite strongly, then you would think they would take that into account.
The department actually said that at the time that they talked to us in December, they said there were no concerns from wholesalers about community pharmacists being able to pay their bills that the officials were aware of, and they described some issues being raised some time ago. Again, is this some? Would you paint that as an accurate picture?
The email I got was end of December, beginning of January. So that probably that was after your meeting.
After.
So perhaps that's what's been the catalyst for the email.
So, but they had told
Prior
us
to that, it was a year before.
it was a year before, so
Yeah.
some time ago.
Yes, yeah.
Okay. And the department said that they couldn't comment on commercial agreements between pharmacies and wholesalers. What you've told us that, I don't know, excuse me if I get the numbers wrong, 367 pharmacies haven't paid their bill on time out of 414.
414.
So my count, that's nearly 90%.
Yes.
Yeah, that sounds like a hugely significant number.
It's a number that's got bigger, and it's a worrying number.
Has got bigger in the last year as well.
Yes.
So it's an increasing problem. And in terms of credit insurance, you've mentioned that you're finding it harder to get credit insurance. Have you raised that issue of credit insurance formally with the department?
Let me see. Yes. So in the email I said to them, I'd mentioned that Bestway and Lexon have pulled out from Northern Ireland. The issue we have is we cannot get extended credit with our insurers for many of the customers, as our more recent results haven't been particularly positive.
Okay. So you wouldn't consider it regular engagement. You're reporting very strongly that your customers are having problems paying their
Yes.
bills.
Yeah.
You're reporting also to them that the issue of credit insurance.
Yes.
So the department are very versed on this by yourself. They've had, very, very strong reporting from yourself that this is happening.
What you might find though is that full line wholesalers historically have been the larger suppliers of product. The landscape has changed over the last 20 years in that certain full line wholesalers will not hold a full branded product range. So in the past, a short line wholesaler just kind of come in and mopped up some generics, but they possibly don't understand the size of the supply chain that we are in Northern Ireland.
You're being treated differently in that, as you say, the main wholesalers would stop an account after 30 days.
Yes.
You're more flexible, so you're more exposed to
Yes.
to people who are having financial difficulties, and
Yes.
that they would ask for credit extensions and things like that.
Yeah.
So in many ways, you're the early warning system.
That's what I'm saying. We're in a unique position.
Yeah.
So we know about it before full line wholesale because they'll pay their full line wholesale bill because they have to get branded medicines because they have to fulfill prescriptions. Whereas if they can put us to the bottom and they can speak to my brother and say, oh, it'll be in a week, we've got to make commercial decisions. And sometimes we have to put people in stop.
So even though you're flexible, at
Yes.
some point it will,
Yes.
it will
Yeah,
have
of
to
course.
come to
Yeah.
a stop.
Yeah.
There. I know we've heard particularly, but can you just give me your opinion as to why pharmacy owners are struggling to pay their bills? What have they told you?
They've told us that they're not getting paid enough for the services. Well, they're not getting paid enough for their drugs. So the clawback is killing them. And it seems like I think as the chair said, it seems like a nonsensical way to run a business.
I noticed actually we got on our table papers, we got a pharmacist that sent us some price comparisons, and some of the drugs they list. One of the one is aspirin, 75 milligrams, which is I think the drug that you mentioned for stroke and heart attack prevention. And they lose £1.25 every time they dispense a box of aspirin. So which seems.
We've also got on top of that. So aspirin in particular, we received 57,000 packs in last week. This product is short in the market. The price to us has gone up, so we then have to pass that price on, and so that then accounts for that price difference. Now, if you're running a business like mine and you've got to make a commercial decision who to sell that to, you're maybe going to sell it to the people who are going to pay your bills. So there could be a situation where the Northern Ireland pharmacists might be a bit further down supply, the food chain.
So people who are already struggling financially because of the clawback and because of the funding issues are going to find it harder and harder to get.
Well, they might not get access to the product because I've only got 57,000. So who am I going to sell it to? I know that's not. It would be nice if we could give 4 packs to every customer, but that's not Right.
Northern Ireland pharmacists are particularly exposed in that we don't have the same range of suppliers, and we are financially depressed because of the funding situation as well.
Exactly.
Okay, thank you. Thank you, Chair.
Thank you. Colin?
Thank you very much, Chair, and apologies for not being in the room. If I was, I would probably give you all the cold, and then you'll end up having to go and get some of those drugs. So it's probably best off that I'm on here online with you. Lots of the issues have been explored, but I think we just need to remember a reasonable fundamental issue. When you get sick, you go to our National Health Service. If that is in the community, it is to your GP. Your GP writes you a script, and then you take that to a pharmacist and you get your drugs. If in that process the pharmacist has to put their hand into their pocket and pay for that drug for you, that is utterly ridiculous. It is just utterly ridiculous. But it is what is happening to the tune of millions of pounds across our community pharmacy sector. I cannot understand how that can be put any clearer than we have heard from the panel today. And I think that we have to look as to how we make the representations into the department to make that case clearly. There has been an increase in the budget, and I think it was really well put by Turlock, where he said it's the equivalent of giving the pay rise to the nurse, but asking them to work 2 extra hours. So that budget is not just comparable to say that it has gone up and therefore the sector is better off. It is absolute folly for the department to expect us to believe that. And I think what we need to do, and I would ask the panel if this is possible, are there about a half a dozen very simple, very straightforward, very short questions that they could put together for us that we could present to the department and ask for an answer so that we can make our own determination? Because this toing and froing back and forward is not doing anybody any good, not least the patient, because ultimately they are the people out in our community that are going to end up not being able to access the drugs that they need because somebody has got their head lodged somewhere in the department saying, oh, they're all right there, they've got plenty of money, they don't need anything extra. We wouldn't ask anybody anywhere else to pay to do their work, and we should not be asking our community pharmacists to do that. So can I ask the panel, would there be 5, 6 questions that they feel would really be able to put down a bit of paper that we could submit to the department and just clearly ask, and then based on those answers, we'll know what we can do next?
Yeah, I think it'll be the same asks that we have already made to the health minister. We're happy to provide those subsequent to the meeting, Colin, and to link with the committee accordingly. I think it's important also to say that, in terms of the price increases, there is a mechanism within the drug tariff whereby they do adjust the price, but quite often that price does not match the market price. And, even though there is an adjustment, it still doesn't cover the cost of many drugs. And I know the team in the office have a list going in every Friday the length of their arm of such drugs. So this is there are mitigation steps, but they're just not anywhere near the real market price.
I think those questions would be really useful, Jude, that we could just submit them, and we know that they're the straightforward questions that you're looking the answer for, and I hope that we as a committee could then submit those questions and then get those answers and determine from there. And in terms of the clawback, I just think that it's ridiculous that it's 2026. I mean, AI and other advancements means that we can fly airplanes, we can do all sorts of things across the world, but our department can't work out that exactly penny for penny that a community pharmacist has to pay out for drugs that a GP has written a script for, that there can be a way of vouching that, and they get exactly the amount of money that they have handed out is exactly the amount of money that they get back. I think that this space that is created through the clawback just allows the department to be able to hide behind a smokescreen of underfunding the sector. And I think that there should be real questions to answer by the department as to why they can't say pharmacy A has spent £250,000 on drugs, so we give pharmacy A £250,000. I don't know why they have to put in a little algorithm that just makes up somewhere what they think you might have got as a deposit. I think that technology should be able to try and meet the exact like for like refund. And I wonder, is that something that is done elsewhere and something that might be possible?
Probably not, being realistic. If I'm being entirely honest, such a large market with multiple suppliers, and we're a decade behind in IT systems for prescriptions, for example. And so that in terms of the work that would be required to integrate commercial systems with API feeds and things like that, it probably isn't. And again, when the clawbacks, it's an issue because of the allowed overall level of margin. If you examine that margin, or the element sort of your funding that comes from that procurement margin is that core part of your funding, that number has increased, and the number of packs with more prescriptions, more drugs, more cost, population. So that has increased over a number of years, and the costs associated with that. Whereas in terms of a percentage, that number hasn't increased. And whilst it would be fabulous to be paid exactly for every pack and everything, there's an acceptance that it probably isn't pragmatic in terms of doing that. The problem really comes, and why it becomes such an issue, is when you're really, 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 really squeezed on the vast majority of things, those little discrepancies really matter. Where there's more breathing space in terms of that overall funding system, it has less of an impact in terms of the overall contractor level impact as things are moving along. And again, because it feeds in as well to the difference in the types of shortages. The department will talk about, and they are UK-wide shortages and issues and problems that come from that, but there are, on top of that, compounding it, the Northern Ireland specific factors. And poor analogy possibly, but it's a bit looking back to your past and toilet roll again during COVID. And that if when people are trawling around shops and trying to get them, and they'll go into the big supermarket and they've gone out, and they'll go into the medium-sized supermarket and they've gone out, and it'll be the local shop and the smaller shop, and the breadth of different vendors that people were going around and buying everything, in effect, where there's a shortage of medicine, the same happens. So there will be residual stock that tends to balance out. If something goes short and it's out for a little while, there'll be some stock in the system, and people hunt through the suppliers, and as you get down to the smaller vendors, you can pick up stock, and so that product could be back in or stabilised a little bit before all of the stock in the market's exhausted. The issue that we face in Northern Ireland is we have a lot less opportunity to do that because we have less vendors. In doing that, there are products that I can see for prescriptions at present that I can see vendors in England have that I can't get in Northern Ireland. Those patients can't get that product. And that's specific to the difference here. Those vendors will not ship to Northern Ireland. And again, it is departmental policy that creates viability within the supply chain. The department set the prices, the department set the margin. And in any economy, a monopoly purchaser that controls the margin cannot simply say that it's not commercially viable because of some other reason. It is departmental policy that have created a lot of these, and that will be based upon UK-wide DHSC policy, and we do have a Northern Ireland drug tariff, we'll copy and paste England in reality, in terms of the pricing. But there are differences here and there, and whilst they'll say, the department may say that, we look back in margin survey, we'll check how things balance out, it's about being network-wide in terms of the funding and different things. It's really tight, so those small differentials matter locally. That margin squeezed, you've fewer vendors, and ultimately it's the patients that suffer, that can't get access to continuation of therapy. And that's where the risk comes. And it's difficult to know in discussion with the department what the reasoning for not accepting it is, or there's at times I think that the department don't necessarily have a very clear understanding of how the supply chain and the actual model and network works through that supply chain and the impact, because it's categorically incorrect to say that vendors leaving Northern Ireland for commercial reasons are beyond, any influence from departmental policy. It's categorically incorrect.
I don't think I'm much further forward with that explanation, Tony, because I'm afraid as a layperson, to me, if you hand out £50,000 for drugs, then you should have receipts for £50,000 that you can claim, and if the department only gives you 40, then you turn around and say, well, why are you not giving me the full amount? But if there's a background and explanation that's complicated and difficult in there, it makes it difficult to argue that case. But I hope that we can continue to get a fuller understanding of that, to make sure that we don't have pharmacists putting their hands in their pocket to pay for drugs, to subsidise drugs for patients, because that fundamentally does not feel like it's right. And it's a right that I think we should have to put wrong, or to fix, so that we don't have community pharmacists that are out of pocket. But Sharon, thank you very much for the questions. Thank you.
Okay, thanks, Colin. Nola?
Thank you very much for the presentations today. The last time you were here, we discussed again the discrepancies between what the department think is correct cost of service and yourselves, and we asked you, and we asked the department, will show us where the money is, show us the paperwork, show us. And to be fair, you invited us. I went along to my local pharmacy, and you were there with Crossings Chemist in North Belfast, and we went into the system. We saw how they order from the wholesalers. We talked through it all quite in depth, so that we could understand a little bit more. But we didn't then get that from the department as to why they come up with their cost and how they get to. But yet, quite simply, we have an example here in front of us of someone that someone has, I think, already said. Aspirin cost to buy £2.25, getting paid £1, losing £1.25 per item. And then we have propanol, another example, 63p, and another one, £57.54 lost on one script. So we're able to outline what we are losing. And I understand what you're saying, Turlock, from there are some that you're kind of write off because they are so small. I imagine they are not going out of stock. They are very generic, they'll be there, etc. Or your reasons for why they're so small. But you'll still also have an end of year finance report. So it's not like you might have a receipt for every single item, and you likely will, but you have an end of year finance report. So those figures can, in my view, against what the department are saying, can still stack up. So have you received that information from the department as to their analysis? Have you seen that paper trail or that work as to why they have come to something different? Because I haven't. Have you?
Oh, I mean, as I said, it's a very unilaterally decided mechanism and model. And I think at times what the department will say in relation to, say, for example, some of the medicines that are being bought below cost, and you have to bear in mind that there is an adjustment sometimes, but that adjustment may not come anywhere near what the market price is. I think what the department will say is, well, there's swings and balances. It's not to say that every drug is there's a guaranteed margin, but overall there is a guaranteed level. And our issue is the guaranteed level is wrong because it was set wrong, and it comes back to what Marie was saying earlier. Our funding was fundamentally set wrong back in 2017-18 when the opportunity was there to set it on the right path. You then go forward at a time, and then if you're carrying a £30 million deficit in the system, and you then have a situation where last November there were 100 lines, 250,000 packs being affected, to then December 650,000 lines, where there's a price issue. Suddenly that puts the discrepancies then add to that £30 million deficit. That's why Nigel is reporting the level of non-payments, because you're carrying that level of underfunding, and then there is the additional element of margin being lost in the system. The whole thing needs to be negotiated and agreed. That's all we want to do, because when you then add in the fact that you're deducted the clawback on generics, probably £15 million worth of clawback is taken off generics, zero discount on generics. It's just set up to fail in essence, and we're watching that now. And the problem here is, this is one of the key functions of the health service, is that people can get the medicines that have been prescribed for them, so that their conditions can be best managed in a timely manner and in a manner in which is conducive to their health improving. And pharmacy is struggling at the minute to carry out that basic function, for reasons that, as you've heard today, not only are impacting on community pharmacy, but are impacting on the wider supply chain. Nigel talked about he was fortunate to get a supply of 57,000 packs of aspirin. If one of those other wholesalers had managed to get a supply of 100,000 packs, we have no access to that. So this is why Northern Ireland is in a disadvantaged state, as well as, unlike Scotland, we get the clawback applied as well.
And What will it take then for the department? They don't see that it's a big issue. They're not seeing as that from the wholesalers there's a big problem. They can't comment or interfere in commercial contracts, but they can sure as heck set the policy that controls it. What will it take for them to understand that this is an issue and something is not right here?
Patient outcomes. And this is what we're saying. We're getting into that space here because of the sheer volume of lines affected. I said in January there was about 149 lines that were granted those concession prices. We're already at this stage, and I think we're at about 160 lines, and there's still probably another price released tomorrow. So the numbers are growing here at a rate that the market is just moving completely away from pharmacy. And our concern, as I took the call and dealt with a lady who feared that she was going to go blind, that's the outcomes that are going to be seen here. And as Eamon Gillen reported, they see contractors on the ground, pharmacists on the ground are worried about the patient outcomes here, and as are we. And what we're saying to the department, what we're saying to the ministers, work with us to do the best we can. Part of it is that the minister steps in to try and secure additional supply of medicines into Northern Ireland from existing UK stocks. He has to try and step into that space. It was done for Brexit. There were steps put in place ahead of the pandemic so that community pharmacy was stabilised, and we're at that stage. It's
So it's not that we're not sure what else we can do.
Yeah.
We've tried to, suppose, lay it as bare as we can. And we've talked about this element around medicine shortages and the safe supply of medicines to patients, which is at the core of what we do. But I also think it's really important that we remember the accessible access to healthcare that community pharmacy presents on our high streets, our shopping centres, our communities. And Colin talked about how a patient's sick and they go to the GP. Absolutely, but if a patient's sick, I bet you they're more likely to present to a community pharmacy because they're more accessible, and that is the huge risk. We need to ensure community pharmacies are maintained within our communities so that we support the health service in the right way and provide the access to services that we know is possible, that we can see in other jurisdictions, that we want to ensure that we keep developing the profession in that way so we deliver the best for patients.
You both have mentioned, about ensuring that you can pay and that they are sustainable and remain in the community. I have had in North Belfast in the past few weeks a number of pharmacists reach out to me, and one has said in particular, he waits for the email from BSO at the end of every month detailing my payments before I can look at my outstanding invoices owed to drug wholesalers to see which ones I can pay for supplying urgent medicines to me immediately, and then goes on to say about how it's those urgent ones that are taken. There's issues there about having to take personal loans. There's cash flow problems, and it's gone back to the issue of the wholesalers. Then we have an NHS. It's supposed to be free for all. I'm assuming that trusts get their medicine from wholesalers, and do they have the same problems? Or will their bills always be paid to the wholesalers to enable the patients in hospital to get their medicines?
The key difference with the trust is they don't operate off a tariff. So in effect, we have a payment price that we get paid for that product. With the trust, they'll have a number of different ways that they'll procure. So for example, that they will sometimes tender out over the course of a year, and it'll probably give reasonable value on the market at that point. The difficulty in community that we would have is if I tender now for aspirin, I don't know what price I'm getting paid for the stock I've already given out this month. So I sure as heck won't know what I'm getting paid in 12 months' time. So it's an impossibility. So it's reliant upon spot purchases within the market as effectively as possible. But equally then, if manufacturers will sometimes pull out of those contracts that they will have, the tenders, if the price has gone up, and the hospitals will buy from other wholesalers at just whatever price it is.
And just at whatever price it is. They will make sure that their patients in the hospital get those medicines at whatever price there is, because they are not the ones that are paying the bills at the end of the day. And rightly so, those patients should be getting that medicine. But it's almost like you're in hospital, you get your medicine, you're treated. Now you're back out in the community, but you've actually to stay on that for 6 months. But good luck to you, and find your pharmacist who'll find you that medicine. That's not an NHS. That isn't an NHS model of delivering care, and it's something that that we do need to fix. But in terms of the price differences, where are the price increases originating from? If we are talking price increases of drugs, so before the wholesalers, where are the price increases originating from and why?
So for the aspirin example, so there is a shortage of aspirin. I think it was because there was a batch problem with one of the manufacturers. So as soon as that happens, the market, our wholesalers cancel our back orders. That's just what happens, and they say we've got 57,000, and your price is £2. So we then go to the pharmacist and say, listen, we get stock in, but we're going to have to charge you £2.10, £2.20. And they say, well, they then make the decision of whether, and we've got certain people that we would go to ask if, would it be reasonable? And so they then tell us, yes, that's fine, we'll buy it because we need to supply our patients. So we then order 300,000, we get 57,000, and then we have to try and spread it out and supply our so that's where your price increase comes.
And
it comes from the manufacturers.
Yeah, and that's for aspirin because there was an issue.
Yes.
So is there someone down, because we are reading global issues, is there a manufacturer, someone down the line who is actually just making a lot of money and increasing prices for drugs and having this knock-on effect for the wholesale for community pharmacy? Or is it because there are things that are inescapable and out of control, out of anyone's control?
So I think there's two types of shortages we have to get clear in our head. There's the chronic shortage of a weight loss drug. So one of the weight loss injections, we can't get it because it's been sold online. So that causes your global shortage. The aspirin shortage is a shortage that might only happen for 6 weeks, 8 weeks, maybe 2 months, 3 months. But what that does then is throw that price up, so you're having to pay that £2 or £3 extra. So this is a national shortage, so let's call it a UK shortage. But there's 160 products that's affecting, and over 500,000 packs. So the knock-on cost-wise is huge. So it's the global shortages you're hearing about are the ones you see in the front page of the newspaper, and that's your weight loss drugs. These are the things that people need every day. Aspirin, as you say, it's given for people with heart
all
conditions.
140 lines.
Yeah, I think it comes back to Turlock's point earlier around the model. The model at how the drug prices are set in Northern Ireland and indeed across the UK has been something that's been in place probably for 20 years now. And in essence, the UK would have the lowest prices of medicines probably across the developed world. Okay? So if I give you an example of 10 years ago, there were about 30 lines, generic medicines, that chemists were paid less than £1. Okay? So that meant that the whole supply chain had to get it into the system. Pharmacies had to buy it at below £1, try to make margin to make up the shortfall in the fees, etc. But that was the extent. There was about 30 lines less than £1. In January of this year, there were over 160 lines that were over £1, which means that the industry is trying to make the drugs cheaper and cheaper. Now, when you have a situation where there's a supply constraint, so it may be licensing issue with a particular manufacturer, and you've got to remember a lot of generics are manufactured in other parts of the world, so those medicines have to travel maybe from the Far East right across the system. They have to meet all the regulatory systems and checks and balances and come into the UK to be sold at £1. When there is a supply problem, if you're a global manufacturer, are you going to look at where you put your product in? Do you put it into the market that if there's a supply constraint, that you put it into the market that is going to give you the lowest return, or do you put it into a higher? So that's what's causing the wider element of supply chain issues with generics at the minute. And we actually said to the Minister, we can see a price, a market correction coming. And that's what we're living with at the minute. It's happening because of wider issues. But particularly then in Northern Ireland, Nigel has a limited stock of the stock that he can get. We have fewer suppliers. So this is why Northern Ireland is getting hit harder than other parts of the UK.
And on top of that, the correction you're talking about, we've got quite a lot of manufacturers who have come into us at the start of this year and said, listen, we're going to rationalise our product range because we're selling Benjaflu's to you at 13 pence, you're selling it at 14 pence. So nobody's making any money on it. So we're going to stop supplying it to the UK market, and they'll supply it to the German market. The German market's very lucrative. They'll just make enough there, so there's no point in supplying the UK market if the prices are continually getting driven down. What you've also got to remember is that pharmacy is actually doing a really good job in managing the budget, because it's the pharmacists that are talking to us to say, well, we need a cheaper price. We try and do as cheap a price as possible. That's reflected in the margin survey. So the pharmacists are actually doing a job of regulating the drug bill themselves. But
value isn't being recognised of what A, the sector is doing for the health service, and B, what we're doing in the process of managing the drugs bill. There has to be an economy that works for everybody, and it has gone too far, and there's a situation now where we're in the midst of this crisis, I would have to say.
Thank you. No further questions.
I live in a small rural village, and I can remember a time before there was a local pharmacist, and I see the positive impact that the local pharmacy has in terms of just all the service that they do. I take your point, Marie, local people go to the pharmacy probably before they go to their GP in a lot of cases. But I'm going to ask a very potential controversial question here. Do you think the department thinks there are too many pharmacies in the north and are not engaging on this issue because they would be potentially happy to see pharmacies leave?
I think at the Health Committee in December, I think when the officials were asked that, there was an unequivocal no, there's not a view to that effect within the department. Whether or not what is behind the scenes, we're not privy to. What we will say is that when you look at the activity that is undertaken in pharmacies in Northern Ireland relative to the other parts of the UK, the pharmacies here on average are much more productive, much more active, are providing more services, more dispensing than any of the other regions. So in terms of, if you look at Scotland's model, we're slightly ahead of Scotland in terms of how busy the pharmacies are. Scotland has the stability of a model that works. We are in a situation where we're busier, but our funding is wrong. It's creating that instability. I think what you've got to remember is that within the health service at the minute, there is the whole reset agenda. This is about moving care from secondary care into the primary and community care. There is the talk of the development of the neighbourhood model and so forth of healthcare. And actually there is a greater emphasis being put on providing healthcare support to patients in their community. Community pharmacies, as you have indicated, are community health hubs, and they are the glue that holds many communities together. I worked in a pharmacy in Craigavon. We had a small precinct type area, and the other businesses around us were always saying to us, don't you ever close, because if you go, they will struggle as well. This is about what the health services priorities are. If you're serious about putting care into primary and community care, you've got to put the investment into it. And what we're saying is we're up for doing what we can to help patients in Northern Ireland, and the health service manages the challenges. Are there too many pharmacies? You go to a pharmacy and see if many of them are standing around. They are flat out. So all we want is to be stabilised so that we can play our part, because if the direction of travel is more into primary and community care, you've got to put the emphasis on stabilise primary and community care.
I mean, and just a supposition that if that was the department's view, likely the community or the pharmacists that suffer would be the ones in rural communities, which would have a huge impact both in those rural communities but also in the department's model moving forward, as you're suggesting, neighbourhood. Anyway, Dan?
Yes, thank you. So just a couple of questions, just to try to distill this down into, and George, you and I spoke about this yesterday, so full disclosure. There seems to me that there are two asks really in relation here. One is kind of about the long-term contract that pharmacies can have with the Department of Health that would be similar to a contract that the GPs currently have. I mean, I'd like your assessment just quickly. Is that going anywhere or isn't it? And number two, then the issue of the clawback, which seems to be the core issue that would provide some kind of stabilisation plan in the meantime for pharmacies. So are those two thoughts the essence of what we're talking about?
Yeah, in essence, that's what we're
Yes.
saying. It is a way forward, and that is what we've been advocating very clearly.
What has the Minister said about the contract?
The Minister says, as I think he has said to you, there are different forums for CPNI to raise those issues, but nothing's, in an overarching way. So we are being shunted into forums that really don't have the remit to do what is needed.
Can I summarise that as the Minister says nothing's happening with the contract?
If you look at the history
just to
over
be
these
blunt,
last 15
I mean,
years...
it's time.
yeah.
It's time to be
Yeah.
blunt, because we've been back and forward and back and forward on this issue all the time. There's little point in this, because you're in a room of people who's, you know where my office is. You know how many times I've been and how the contact I have with my local pharmacies. So we're all talking to ourselves and we're all agreeing, but obviously the Minister is saying something very different. So to be blunt, the Minister's saying the contract negotiations is not the way forward. I'm shunting you off into this discussion or that discussion or the other discussion. Is that where we're at?
I think that's a fair summary. Dan,
okay.
I've been in the chair role at CPNI for about 18 months, and we do correspond frequently. We meet frequently with the department, but in none of those meetings do we have an opportunity to look at the totality of a contractual discussion.
So if we were writing to the Minister, we would need to write about the long-term future of pharmacies, and that would need a much, much greater emphasis on the contract and how pharmacies are contracted by the department to deliver medicines to local communities. It would need to be on that.
Negotiations around
yeah.
a contractual position.
And
for
the
us.
second thing then is this issue of the immediate stabilisation of pharmacies. Now, I've visited pharmacies. I have 3 large towns in my constituency. I've visited pharmacies in Banbridge, Portadown and Lurgan. So I've been around them all. And, it is the issue of payment for drugs, and the issue then of the arrangements with the like of yourselves, Nigel, as to how that works. So you're saying that the clawback mechanism, even some progress on the clawback mechanism, would make a substantial difference. As I do understand that the Minister is saying things are constrained. We've just received an email which says the Minister and the Executive have agreed the deferral of hospital car parking charges because of the issue just of funding and the impact that would have on the health service. So I accept entirely that funding is constrained. I've no argument with that at all. But some movement around that would ease the pressure on community pharmacies. Those are the 2 things really in essence that we need to talk about. It's really important. Nigel, anyway, we will have a discussion as a committee about that as the way forward, but that's in essence what I see as the 2 things that we need to grapple with. I was really interested in your presentation. So, for example, can you describe to me I understand that one of the drivers for medicine shortages or potential medicine shortages in Northern Ireland could be the Northern Ireland market, payments, etc., and just the fact that, if the market is largely GB centric, that it is just a bit more expensive to supply medicines here. So I get that. But what's the relative difference between the potential shortages in the GB market compared to Northern Ireland? Do you have any sense of because I was actually talking to one of my local pharmacies, and the pharmacist there said, we actually discussed aspirin as one of the drugs, And the pharmacist said there, but this is a UK-wide, a UK and Ireland shortage. And of course, that's what the minister's hiding behind in his letter to us here in the committee. That's exactly, this letter is full of jargon about protocols, but nothing very much about what exists underneath protocols. So can you describe to us what's the relative difference?
So what we do as a company is we've got different sales representatives, teams that deal with different regions. So we would, if we get 57,000 aspirin in, we would allocate it by turnover. So if the Northern Irish Territory turns over £4 million a month, we would allocate that percentage. So we do it quite fairly for our sales team and for the region. So we try, Diane, to spread that around. But
you're allocating it on turnover, not on need. Is that fair to say?
So.
And I understand that that's a commercial decision. I get that.
No,
but
it's not necessarily commercial. Well, it's really our only way of allocating it, because there's a need across the whole of the UK. So 57,000 aspirin isn't enough to supply the whole of the UK.
So are we more likely to have a shortage? And I'm only using aspirin because I don't know the other drugs, and we all know aspirin used for blood thinning, etc., etc. So it's easy for lay people like us to use that. So what's the relative shortage then in, say, Bristol compared to Belfast?
I can tell you.
We don't know. We can't weigh that up across the whole of the United Kingdom.
No,
is that what we're saying?
What you can say is that if I allocate 10,000 packs to Ireland, and the price is £2.20.
Yeah.
We might find the pharmacist in Ireland would not buy the stock because they are not getting paid quickly enough, or they're not recognising the increase in price quickly enough, and they are nervous about buying it and adding to their loss. So we're finding that if you look at a pharmacy in Northern Ireland just now, compared to a few years ago, their margins are lower, and they're not doing as well. So I'm not saying they would shy away from dispensing things that they're making a loss on, but because I can't comment on that, what an individual might do on a daily basis. But if I've got 57,000 packs of aspirin, I might find that somebody who isn't financially constrained might buy it because they're not worrying about the risk of non-payment.
And your question can also be answered in terms of the comparing Bristol to Northern Ireland. As been covered earlier, the pharmacies in Bristol will have a bigger range of wholesalers to access the aspirin from. We've covered already the wholesalers who've already exited the market. So in Northern Ireland, there's a much smaller choice of wholesalers to go to access the aspirin. So Nigel's talked about how he would try and allocate it as fairly as he can across the whole of the UK, but we've already lost the numerous wholesalers that we referred to earlier. So pharmacies just cannot buy. So I think it was Turlick said, so in the system he might see that one of those wholesalers has stock for the pharmacy, say if it's Bristol we're using, but he can't access it because they don't trade in Northern Ireland. So that's the disadvantage that we're at because of decisions that have been previously made.
Is it fair then if we categorise this as there is a potential for a general shortage in aspirin? Again, I feel a bit daft using one particular drug, but a general shortage in aspirin across the whole of the United Kingdom, but the actual specifics and nature of the Northern Ireland market drive that more acutely.
Yes,
Is that correct?
So that example there, if we go to the manufacturer's side, the manufacturer will say, okay, there's a shortage of aspirin, we've got 1 million packs, so what we're going to do is we're going to split it up amongst the people we supply. So we supply Ethogen X amount, so they'll give us pro rata for what we get from them. So say it's 57,000. The rest that they're going to allocate might stay on the mainland though, with the Lexons and Coloramas and Bestways of this world. So in essence, you are getting less of the product supplied to you because the manufacturer is choosing to allocate it in a way that they seem sensible but as you say, the supplier isn't actually based in Northern Ireland, so they're not supplying the Irish market.
Is it easier for pharmacy chains? And I don't know, in my head I'm thinking they might be more resilient so Boots, for example. Is it easier for pharmacy chains than individual pharmacies?
I would answer that, Dan, by saying not necessarily, because I suppose in a chain the size of, we've obviously pharmacies in Northern Ireland and we've pharmacies right across the whole of the UK. Our pharmacies are probably a bit more fortunate in that they will have some people who that's the role they will do. They will work in the background to secure stock, work with wholesalers, etc., to bring that stock in. But for example, in Northern Ireland, we will use one of the mainline wholesalers to bring the stock into our pharmacies. We will have to use the others to access stock that they don't keep. So would I be one to put in record that we would be more resilient? No, because we will experience the same issues, absolutely the same issues with shortages. Aspirin being one of them, that my pharmacies over the last number of weeks have had to deal with the challenge of aspirin going short in the market as well, and working with their patients, working really hard in the background to try and secure the stock that they can for the patients, and if there's no stock there, again, work really hard to try and find alternatives, because I think, we've touched on it a few times, but the amount of work that is undertaken by community pharmacy in trying to procure stock, we've talked about the financial benefits for the Department of Health, but nowhere does it really recognise the amount of work that's actually undertaken by community pharmacy contractors and pharmacists and their teams across Northern Ireland in procuring that stock. Unlike the question that was asked by Nuala about the hospital setting, there'll be a whole team procuring stock in that secondary care setting. It's actually community pharmacies who are undertaking that role as part of the work they do in their teams.
No, and I to be fair, I was talking to one pharmacist in Portadown who said, I close on a half day on such and such a day because I need that day to look at stock, look at where I can buy stock at the best value so that I can, presumably lose less in terms of clawback and so on. And I to be fair, I know that. My last question really is around the neighbourhood model. So we're told by trusts that the department, and the permanent secretary was at the committee a couple of weeks ago, and he indicated that 2% of trust budgets should be spent on the new neighbourhood model. Now, forgive me, I've been here a long time, and I would hate to see the trusts try to get around that by repackaging or rebranding some stuff that they already do. But no doubt we'll have a good look at that when we see more information on it. But it also seems to me that community pharmacy is like GPs. This can't operate, it can't work unless community pharmacies are sustainable, viable, and can find a way forward. So have you had discussions with the Minister or his team in relation to how you would be included isn't the right word, but be that mainstay of what would be a new neighbourhood model?
So I think whenever the neighbourhood model was announced back in September last year or thereabouts, there was a series of work streams then set up, and Marie and I sat on some of the work streams that looked at what needs to happen next. There were 3 stages to it. So design the model, then look at how it might be implemented, and then deliver the model. So we're at the stage now where, in essence, according to the original time scale, there should be implementation of that model from April. Okay.
Yeah.
We also had an information.
We had discussions about the commissioning and the money behind the model,
Yeah.
which seems to me, if we're not going to have progress on the clawback and we're not going to have progress on the contracts, are we having any progress in relation to that?
What I will say is that we, as a sector, met with the leads who are charged with the responsibility of developing the model back in November. There hasn't been.
Of course, it is the same leads is responsible for community
And
pharmacy, so they're very well versed in how this works.
I'm deliberately trying not to make any point there in that at all. But we haven't had any direct engagement since. There was a webinar that I attended last week or the week before where we got an update on where things were at. And in essence, my understanding is that there is an imminent policy paper to be published along with the resource paper. That's coming at this stage, probably 4 weeks before the go live date. We have had very little visibility. It's not to say that the work's not being done, but we certainly haven't had the visibility. That's not a criticism, that's just the reality of it. And you know, for something that is you know, a significant change, nobody I think yet can see how the model is to be set up, how it's to work, what the budgets are, what the responsibilities, what the roles and the remits, etc. So there's more questions still at this stage for us than answers, but we have given an assurance to the Minister that, you know, in the same way that we are, as a sector, are recognised as being a key part of it, we want to be a key part of it, but we have to be able to do it in the context of being able to operate pharmacies, because they are neighbourhood healthcare in reality.
Yeah, so it seems to me that we're really down to sort of kind of, if I try to summarise this in sort of 3 points. One is the long-term contractual arrangements with pharmacies, the issue of the clawback and the issue of how you fit in with the neighbourhood model and whether or not there will be any further funding in relation to that. Those are all, and I know the committee will consider all those. But thank you very much. I think it's useful when we try to do that. I'm still interested in the differences in the two markets, Nigel. I'm not sure I've resolved all of that in my head, but thank you.
Thanks, Dan. Alan Robinson.
Thanks, Chair. Just a couple of quick questions. Of the 29 pharmacies that have closed in the past 10 years, how many of them did they cite to you that closed as a result of the pressures and the underfunding? All of them?
I would have to say that a pharmacy and indeed any business will stay in operation if it is economically viable to do so. So the fact that there are 29 closures has meant that there has been a decision taken in those structures, in those organisations, that this is just simply not workable, no longer viable.
I suppose that leads me on then.
We wouldn't necessarily be privy to the reasons, Alan, so I'm caveating it with that. But
fair enough. But it was quite clear for many years that community pharmacies cross-subsidise their NHS work with retail income, and obviously there's a how do you put it, a revolution happening on the high street, and there are many challenges on the high street, as we all know. So they've been hit obviously with a double whammy of the clawback and the various pressures of the funding model. They've been hit with the revolution on the high street. So I suppose that leads me on to, are members telling you of, is there, like say for example, any of them defaulting on rates, any of them struggling to retain staff, any of them struggling to maintain buildings, any capital works that are outstanding and they're offsetting because they're struggling?
I think what, and we've been on the record of saying this, is that when you have a model that is not economically viable, people then have had to introduce cost-cutting measures at the extreme, closures. But what people do is they maybe look at redefining and reprofiling and reducing staff to try and cope. Diane talked about the pharmacy being closed so that somebody could do another function. Pharmacies are subject to payment of their premises rates. That's something that we know, for example, general practices they may pay their rates, but they're able to claim it back. As a primary care healthcare provider, we don't see why we should be treated any differently. So certainly that's something that we have flagged to the Minister as well. But I was Danny talked about the all-party group, and I think one of the members commented that in her local pharmacy she could actually see the decline in the stock holding within the pharmacy. So people run their stocks right down, and this is part of a problem at the minute with the medicines. People just do not have, I know when I was in practice, you maybe bought a bulk order. People are working very much day to day trying to get the stock. So stock holdings reduced and capital investment is being put on the long finger because it's survival mode at the minute. I'm happy for Turlock to come in with maybe practical, if any supplement.
It's very much, let's say that in some ways that we've an older contractor demographic in Northern Ireland as well than say some of the other regions within the UK. So it changes some of those choices that people make and sort of have some of the impacts. It can be highly variable, the impact. So that, for example, if someone had recently refit or automated a pharmacy and borrowed, could be £250,000, for refit, in terms of automation, in terms of attempted long-term cost savings, and that, they can be very squeezed and then have issues. People are afraid is part of it. And I know personally for myself, I just wouldn't dream of any investment infrastructure because there isn't a return. And then the difficulty is if you're talking about stock holding, and much as Jared had said, that typically at any point you might sit with £100,000 of stock, as an estimate in terms of dispensary stock, that with a lot of shortages, in an ideal world you would say, well, I will hold much, much more stock and I can smooth that out. But the reality is the opposite is true, because as your margin is squeezed, your ability to pay has been squeezed, people are squeezing and saving where they can, and then the problem intensifies because people are uncertain of pricing on some of those short lines, and you want to hold less of those lines because you don't want to pay extra. And it's, as Nigel said, there may be someone that goes, I'm willing to take a hit for a couple of £100 in aspirin because it's just not worth it to me personally. Even if I lose the money, it just causes me too much hassle and it's too disruptive to workflows. Someone else might say, I can't do that. Mrs. Smith's brought in a prescription, I'll order her box and I'll see what happens tomorrow. The price may be down, the price may not. And so people are making some of those different judgments, but all of these things combine as well to be tremendously disruptive to workflow and within staffing. So where you have pared back staff in terms of cost savings, that where you have a shortage of a product, that may mean going back to a GP to try and get a prescription changed because we don't have powers to change from one brand to another. So it could be, a simple example might be where the department have a policy of prescribing a branded generic. That some of those products, they could be out of stock, so you receive that prescription and that branded generic isn't available, and you may have a generic product available that you can't dispense against that prescription, so you have to go back to the GP. The GP to change that product, come back and get your new prescription coming down, which could leave a patient a number of days without being able to access that. If you hadn't ordered the other product in, it could be out of stock by the time you actually get the other prescription up and you can be back again. And contractors do report it's this yo-yoing, and product A goes short and you change to product B and it's short by the time you go to order it. You don't know if the GP, it's the prescribing decision would be for the GP. They may not feel it's appropriate to change to an alternative, and the yo-yoing back and forward, and it creates additional workload, huge additional workload in community pharmacies, but it also knocks on then GPs as well. And so it's all of primary care gets clogged up, and then in terms of that access, and it's the cost to remedy the problem in terms of the context of the inefficiency and the difficulty that it causes within the entire primary care system. It doesn't just, it's the most impact by far with community pharmacy, but it overspills.
Mm-hmm. Can I just ask a quick question then on, given the pressures that you've highlighted today, and you used the term, Jared, chilling, that 367 figure, the uplift or proposed uplift in pharmacy registration fees, are you hearing concerns from members about that?
I think there was a consultation, the Pharmaceutical Society put out a consultation around the proposed fees, and at the time we did oppose it. The reality of it is it's a significant increase. I know the arguments that the Pharmaceutical Society put forward, including that the fees hadn't been increased in a number of years, and that it needed to be increased so that they had the revenue to operate as a regulator. There were aspects as well that we would have liked the society see coming forward at the time that hadn't been produced. Various documents, etc., hadn't been produced. Those now have been produced. I think there will still be concern amongst the registrants about that level of an increase. There's no doubt about it. It is a financial hit for individuals, and this is individuals. But I think there is also, we're aware of the Pharmaceutical Society in Northern Ireland being our regulator. There is merit in a regulator in Northern Ireland. And, you know, I think the Pharmaceutical Society has its own financial difficulties and constraints. So there's an element that they may well need the increase to try and keep their operation going in a way that's needed. So we have been afforded the opportunity to respond to the Health Committee in relation to the proposed legislative change, and I think we're going to be doing that by next week, formally. But
Linda?
For all of the questions and points that I would want to make have been made, and unfortunately they're the same. Jared, I mean, it's probably back as far as just post-COVID, whenever the clawback suspension was removed, that we had the conversation around the clawback. So really, I suppose my point is, I don't know how we as a committee, how you as an organisation and as individuals keep making the same points to the Minister and the Department, and there is no hearing, there is no listening. None so deaf as those who do not want to hear. So I suppose my source of frustration is, I mean, Deanne's right in terms of the points, but the points haven't changed. The points haven't changed since we first had these conversations. So I don't know how we move the department in relation to this. And maybe it is that issue of shift left and pushing really hard on that particular issue. And if you want to shift left, here is how you do it. These are the things that need to be resolved in order to make our community pharmacies sustainable, because you're right, Chair, it will be the same as the GP's issues. It will be the rural communities that will suffer. So that will be your Fermanahs who've lost their emergency surgery in SWA, lost a significant number of their GP services, who potentially lose their pharmaceuticals and their pharmacy services in rural towns and villages. So for me, I think we need to just have some kind of a focus. How we do that, I don't know. But I think we need to be blunt and just ask the Minister and the Department, give us the straight answer. Are you even prepared to negotiate, even to have a conversation with the pharmacy sector? Because at this minute in time, it sounds like you're having the same frustration as us. You're talking in circles, talking to yourselves, you're talking to people who agree with you. But the people who you need to listen are just not listening. And we as a committee can absolutely press and question the Department and the Minister, but we can't make them do anything. You know, we can't force them down this road. So we need to look at how do we actually put significant pressure on to get answers to some of these things and get some sort of movement in some direction to give some relief. It could be done during COVID. The suspension of clawback happened during COVID. So why not a conversation about how you actually do it in a manageable way? I'm not saying that the Department have lots of money, because they don't. You know, and they are under significant pressure. We acknowledge all of that. But where is the conversation to say, how do we work together to get to a better point? And I just think that we need to get to the bottom of that as a committee, rather than having continuously the same conversations and unfortunately bringing people in front of us to say the same things. And that's not your fault. You have to do that. That's your role. You absolutely need to. And we as a committee need to know what the issues are, but we know them.
I think there's a certain urgency at this time, given the issues that are in the system, as Nigel outlined. Absolutely. I think you picked up on the chilling point. I wasn't aware of that statistic, you know, in terms of you know, that's what the situation was at the end of last month, and it is breathtaking that a health service provider, a key front door health care provider, who in essence is providing a service on behalf of the department, that's the situation they find themselves, that people are not able to pay. And
Turlough point is absolutely correct in terms of the overspill into our GP services, because as a woman of a certain age, I rely on GPs for certain medications, and there were a shortage of, and the pressure on the GP to try then to look at what else, you know, what else they could give me, and I'm one of thousands of women in the same position, but we now have other medications that are in the same position, and it's what pressure does that put on other parts of our health service if somebody can't get aspirin? What does that mean for them? What does that mean for their GP? What does that mean for them potentially end up in their secondary service in terms of healthcare? So I just think we need to get a better understanding of that.
So just for members' information and yourselves, the committee have commissioned the research here in the Assembly to look at the clawback issue. It's in totality and its use and its impact. So, I mean, as a committee, we'll be receiving that in the next couple of weeks. So that will allow us some more information to actually go into the weeds with regard to that, and we will put it to use. I'm just kind of reading from the letter that we got, because the issues, as I said at the start, that we're hearing today, we wrote to the Minister, and pleaded with him to engage. So, I mean, his response to us in January was, I can confirm departmental officials and I met with CPNI Thursday, 22nd of January. The issues on the items discussed were funding, negotiation, drug tariff, clawback, wholesale engagement, medicine supply chain resilience. So, I mean, those are the 5 issues that he is telling us in correspondence that were on the agenda. I mean, we're getting a totally different story. And I mean, just in terms of the kind of two-pronged nature of the evidence that we're getting from the department and from yourselves, you know, he's basically saying, unfortunately, there's a long-standing difference of opinion between the department and CPNI, who represent the financial interests of community pharmacy owners. The information provided to you, as in us, reflects how my department has worked and increasingly increased the current financial investment in the sector despite wider. So, I mean, that's just the scenario that we're in, but definitely in relation to clawback, we will interrogate that in more detail. I imagine the research paper will be very helpful to this committee in relation to that. Sorry, Alan.
Thanks, Chair. My family have been involved in retailing for more decades than I care to remember, and I know that if you sell a product at less than what you paid for it, the question is not if your shutters will come down, but when the shutters will come down. And when the shutters come down, it'll usually be when your cash reserves run out and you could lose everything, lose your family home and everything. So I'm acutely aware of that. You've got to make a profit or the shutters are down. I'm not going to even start to try and defend the clawback system at all. But so I'm going to ask, not a leading question, but in terms of what the department, the figure that you come up with every month, and it's based on all the products that you've bought, are there any wins in that for you? Are there some that you come out on the right side as opposed to the wrong side? But I balance that against the fact that it looks like the department's £23 million in front in that clawback situation. So I appreciate that, but do you have occasional wins within it?
Yeah, I think what I would say, sort of made a reference to it previously, you know, the view on the purchasing of medicines is that there will be some losers, but there will be some gains. And in essence, the department allows community pharmacy £34 million of margin. There is then a joint process to measure the margin, and yes, it does show that the margin is achieved beyond that figure. As I said in my opening address, the issue is that there has never been discussion and agreement around what that figure should be. So in essence, the 34 million figure is the department's figure. And it's based on, at a point in time, a pro rata of England's figure, but that was never discussed with us. If we were to carry out and have the same percentage of England's, our figure would be 44. So suddenly that changes the whole narrative. Yep. And it comes back to that 34, or as we would say 44, is part and parcel of what the overall envelope needs to be. And it's the total envelope that's wrong. The level of the fees and payments is not what it needs to be. Marginally, it's not. You know, it's part of the £30 million deficit, but the clawback is the thing, as you say, that would ease things. But it's there are a range of products that the margin is made on, yes, but the totality of it is nowhere near what's needed, and that's.
Colleagues have talked there about going to visit pharmacies. In fact, I'm going the next couple of days to visit one, and Nuala talked about it was an open book that pharmacists. There it is. There's my figures, or it's on the computer screen, and I think other members have experienced the same thing. And I have no doubt when I go in the next couple of days, I'll receive exactly the same narrative, and will fully understand where they're coming from. And Linda talked about, she can't understand why department officials are, appear to be stonewalling you when you go to talk to them about it, and yet it seems to be on the surface a no-brainer. So, I mean, when you go to them and you put the case that the pharmacists have put to Nuala and the other pharmacists have put to the rest of us, you must be putting that to the department. I mean, what's the response? Is it oof? I don't want to say, or
essence,
what is the response you get?
It is in essence, there isn't the ability to do that. I have to say, and I made it clear in my earlier...
Do they recognise? Do they ever say to you, you're right,
no,
but we can't do anything about it?
And I was coming to the point where I mentioned that they had eased the clawback. The head of the SBPG had taken the decision to ease the clawback on appliances, but that eased it by £2.8 million. Very welcome, and it was great that that intervention was made, but it still leaves the £23 million coming out of the system. So I think there is a recognition that there does need to be changes there. I think the evidence was produced around the appliances. I think the evidence exists around the rest of the drugs, and it should be the same approach taken. And this is why, when you're in a process where there is a listening to the viewpoints being taken and an acceptance and a consideration and a debate around them, then at least you can potentially affect an outcome. But it's whenever there is a refusal to take on board any of your points, you're up against it before you start, and that unfortunately has been the way it has been for many years now. We do negotiate around the margins and various small elements of our funding, but it is around the edges, and I'm not being disrespectful to the engagement that brings that around. It's the totality that we need to
Diane alluded to the question of the big branches, the big pharmacy chains, better protected from this. And I mean, if I go to a supplier and I want to buy 100 cases, I'd like to think I'd get a better deal than somebody who's going in to buy 2 cases. So does that not help the bigger chains? I mean, your buying power, can you not get a better deal than the pharmacist sitting in some village? Can you not get a better deal on your pharmacy purchases?
I suppose you say better deal. Yes, it would make sense, wouldn't it? Would feel that we should have more buying power, and no doubt we will have in certain elements of the business that we conduct, because we have pharmacies that trade right across the UK. But you have to remember, we still need the stock to come into Northern Ireland to be able to access it through the mainline wholesaler. So, because I said earlier, that's where we access the majority of our stock for the pharmacies here. So yes, there might be some commercial deals going on in the background, and I won't be party to all of those either, because as I said, we have teams that look after that. Pharmacies do operate in some buying groups as well to try and make the process, because it's a cumbersome process to secure and procure medicines for their pharmacy. So they will look at working together. So that, so it's a complicated process. It's not an easy process as to how we procure medicines. But I think you talked about going on a visit to a pharmacy, and I think that would be really worthwhile, because you'd be able to see it brought to life in terms of how that particular pharmacy, and I think when you see it, you can understand it better.
Nigel was asked the question about would a pharmacy in Bristol have the same shortages as a pharmacy in Northern Ireland? You weren't really able, you wouldn't be privy to that information, but in terms of yourself in Boots, would a Boots branch in Bristol have the same shortage that a Boots branch and say Bangor would have?
So I'll try to answer it as best I can, and it's simply because our Boots pharmacies right across the UK all use the same main line wholesaler, but they will have depots right across the UK, and those depots right across the UK will secure stock. As Nigel talked about how they secure stock, they will secure stock. So to give you an example, will the depot in Belfast always be out of stock of the same things as the depot in Bristol? No. We might be out of stock in Belfast, but they might not be out of stock in Bristol, and that's simply, it shows you actually how, suppose, complicated the supply chain is.
But there's no discrimination against Northern Ireland.
There'll be absolutely no intentional discrimination against Northern Ireland, absolutely not. But it's just the intricacies of the supply chain. They've been able to, because we're reliant on, that's a third party, it's not the mainline wholesaler we have no direct connection with. So we're reliant on them and how they conduct their activity, along with the teams in our support office, as to what stock they secure. But I won't have preferential access to that stock over any other pharmacy that trades with them.
Final
in
question,
Ireland.
Mr. Chair. Gerard, what would be the typical credit terms that suppliers would offer to individual customers here in Northern Ireland? Would it be 7 days or 30 days, or what would be typical?
It'll usually be month end plus 30.
Sorry, what?
Month end plus 30 days. It'll vary. Now, for example, it'll vary slightly by the supplier, and it can even vary by customer. So, by way of example, for myself, for the 3 mainline wholesalers, 2 take their money out by direct debit just before I'm paid for the drugs that I've given out already. So, in effect, I have to have a month's cost cash sitting there to be ensured that they come out. Then the other mainline wholesaler comes out the same day they get paid, and I pay everyone else after. So when you say about why do you experience, the different reports from the mainline wholesalers and the shortline wholesalers, some products you can only buy from the manufacturer to a deal with an individual mainline wholesaler, akin to having to buy milk from supermarket A, you have to buy bread only from supermarket B, and you can only buy eggs from supermarket C. So if a patient comes in with a prescription for those 3 items, I have to maintain those accounts with all 3 of those mainline wholesalers. With Nigel, I might be able to buy different products cheaper, but that's why you get kicked down the line a little bit, because that it's a full stop and I can get those products nowhere else. And so it's why you tend to see within the short line sector the issues arising more quickly. And again, with some of those, for example, talk about short line wholesalers, and they're not small companies, and the department might talk about smaller companies. They're turning over hundreds of millions of pounds. They're not small companies. Well, certainly from my scale, they're huge companies in terms of operating, supplying hundreds of millions of packs. So there's 3 companies of a similar size to Ethigen within the UK, and as Nigel said, if each of those were allocated 50,000 packs of aspirin by the manufacturer that has stock, 2 don't supply here, Nigel does. Nigel would have to allocate pretty much all of his aspirin to Northern Ireland. Not all of it, but you'd have to 3 times the amount to offset the stock that wouldn't be coming here, even if everyone was putting it in. So it's not an intentional discrimination or anything else like that. It's just the fact that people sell to where the customers are. And for a lot of the companies, they don't have customers here, but they will get stock from manufacturers.
I'm reassured by the fact that you tell me you get maybe 30 days. They'll sit the day before the money comes in, because the next question I was going to ask you, how quick do the department reimburse you? If it's 30 days and then they're taking another 30 days, that would be crippling. So sort of a little bit of reassurance out of that, but I'm sure it's not a perfect situation.
The other thing that I would add, Alan, is that a number of our members have come through to us to say that they have credit limits with their wholesalers, and they will be allowed to trade up until that credit limit. Once they hit that credit limit, to get any further, they have to pay upfront and in advance. And that is another aspect that I think we will see increasingly as an issue here, because with the rising prices of the generics, that will tip many owners into exceeding their credit threshold, and it means they will have to then make the payment ahead of getting the check, the payment from their prescriptions. So that's an added aspect here of it.
Okay, thanks, Mr. Chair.
Good, Danny. And for a quick point.
Just a very quick point. We've heard a lot of really concerning things here today. I know Alan referenced the pharmacies that have closed previously over the last couple of years. I just wondered, if nothing else is done, how far away are we from the medication supply for Northern Ireland being interrupted, and what happens then?
I think at the minute there are medication supply interruptions happening daily. We're already in that space. As I said, I was contacted by a lady. Our organisation, she already is dealing with her local pharmacy. So it is happening. That was a couple of weeks ago. So this is happening on the ground. It's just that we have been trying to raise the awareness of it with the Minister and the Department, so that they understand the urgency with which everybody who has a part to play here steps in to try and protect that supply.
Medicine supply is already being impacted for people.
Yeah.
It's very difficult in terms of, as an organisation, it's such an emotive issue with patients, it's very difficult to be able to raise in a way that doesn't create alarm and distress with patients, over and above what would already be there, and so that it's a fine line to try and trade, to highlight the concerns, to the department sort of in a robust manner, but without creating alarm, in essence.
Yeah, and we've tried to do this in advance. Sorry, Chair.
Oh, go ahead.
No, I was just saying we have raised our concerns in advance of the sort of big numbers starting to appear, so it was to say, look, we think there is going to be a market correction and this will be the consequences of it,
Your concerns are well evidenced. We are well evidenced by that, so thank you.
I've had a local pharmacy, I was just going to say, contact me to say that they have struggled to find medication for a liver complaint that one of their patients has because of the shortages. So, it goes beyond the aspirin.
Cystic fibrosis, there's a range of things.
And that for us, as I said at the start, for us as a health committee, that's, we're concerned about good patient outcomes, about our health service functioning properly, about everybody getting the kind of same kind of treatment right across the north that they should be. So, anyway, we've that was supposed to be an hour and it ended up 2 hours, but it's important that we kind of bottom out some of these issues. So thank you very much for your time.
Thank you very much. Thank you.
Okay, see you later. So members, we did write to the department in the aftermath of the previous meeting on the 11th of December. We got that response from the Minister on the 3rd of February. So we kind of raised those issues again. Just also to bear in mind, we have that research in relation to the clawback issue coming within the next couple of weeks. We don't have a definitive time period. No, okay. So I'm open to suggestions in terms of what we do. Write to the Minister again in the department, and do we leave what do we say about the clawback? Because obviously it would be much better if we have seen the research before we're saying anything in relation to the clawback issue. But the issues raised today in terms of medical or medicine supply shortage is extremely concerning for me as chair of the health committee, and some of the other funding issues are concerning. I think it's also concerning that we have previously written to the Minister a number of weeks asking him to engage in negotiations, and he's telling us that negotiation is on the thing, but we're being told today that that's really a nonsense. So I think that's a concern. Linda, you were looking at?
I think we need to be forthright on that issue around, you getting a letter back saying I met with them, we discussed these issues. Because I'm not saying they didn't discuss them, but that's not a discussion's not a negotiation. Discussion's what we had today. So I think we have to be forthright about that. We want to know, was it a discussion, was it a negotiation? Do you intend to have negotiations, not conversations, not meetings, not discussions, not anything else, but a negotiation? I think we could probably outline, if we're sending a letter now, that we will be coming back on the clawback issue, because I think there is no point in. We are going to be much better informed after the research to put some specific issues to the department. I think that's how we should do that piece. But in relation to the issues you've raised, I think we do have to get the letter away now. But I think we need to be very clear in the letter what we want back from the Minister, so that we are not getting.
And I wouldn't even consider writing, asking questions. I would just say, look, we wrote previously asking for negotiations around core funding within pharmacy. You've responded to say that these are on the, but it's clear that they're not negotiations, so we want proper negotiations in the same vein that is happening with regard to GPs.
Sure, it's just today as I listen to this, there seem to be two issues today. And I'm sort of thinking one of them's a bit of a red herring in a sense, not deliberately, but the shortages is one issue. It's worldwide, and we asked the question there, is Northern Ireland being discriminated? No, we're not. The shortages are worldwide. Like Jared said that earlier. And then we have got the issue of the clawback and the viability and the sustainability of pharmacies because of the difficulties created by that. to me, I think that's the number one big issue that we've got to sort out. The other one is something that you could have another debate about, but I don't think the two are directly connected. They're two separate issues, equally important, but I don't think the shortage has anything to do with what the sustainability of the pharmacies and the money that they pay. I think we need to separate the two.
I think there may be a slight nuance to that, in the sense that wholesalers are, if there's less wholesaler supply in here, then that could potentially impact the amount of medicines that come in here. And if wholesalers don't see here as a viable business, then that could certainly add to shortages. So I accept, I'm not saying there isn't a worldwide shortage on particular medicines, but I do believe there is specific conditions that impact that here in the north, a la the clawback, the cost of medicines, and the fact that some pharmacies, as we're hearing, are struggling to pay wholesalers. So I'm just throwing that commentary out.
We are particularly exposed here. Oh, sorry.
Colin, sorry.
Yeah, thank you, Chair. Chair, can I just ask, in that paper that we have asked from the research department in terms of the clawback, can we try and ask them to give us a good, solid understanding of it? Because I'm still a wee bit confused about it, because we've heard on a number of occasions them saying if we could sort the clawback out, that would resolve all our ills, because that's roughly about what the dent is in the budget. It's about 29 million, and they reckon there's about 30 million of a difference. But I know from my years of being in the voluntary sector, if you got funding from somebody, you had to vouch for every penny that you spent. And sometimes you got a budget up front, you spent it, and then you had to vouch for it back the way, or sometimes you had to submit your receipts to get your money back. And I can tell you, my boss would have been giving me a hot ear if I hadn't submitted a form for something that we had spent and not claimed it back. So I can't understand this thing where people spend £50 on an item and they get like £2 for it. It just doesn't make sense. So can we get that, make sure that research paper we get really explains exactly what the clawback is and why there may be an argument for or against retaining it?
I mean, that will be, and we also will have the research personnel here to take our questions, so that we're completely au fait with the thing. So anyway, we need to make a decision in relation to what we do, so I'm open to suggestions.
Can I suggest that we write to the Minister and ask him, has he any serious intent on negotiating with the pharmacies in relation to a contract in a similar vein to GPs? Because it seems to me that this is just thrown into the long grass all the time, and pharmacies say this is what we need for stability, and the Minister throws that into a discussion. So I think we need clarity around that for everybody to move forward. The issue around the clawback is really an issue, despite the intricacies of the clawback that Colin talks about, of a funding gap. Mm-hmm. And how he's going to address the funding gap for community pharmacy, because it is having, and I think I agree with you in the sense that the impact it's having on the Northern Ireland drug market and the availability of drugs here in Northern Ireland for patients. So I think those are the two really the nub of the issue.
And the other, the thing about it is, right, there's a good chance that the community pharmacy through the clawback is funding other aspects of our health service. So we as a committee need to understand, if that is kept in community pharmacy, then that's like leaving a gap somewhere else. And that's the cause and effect of this. So, but we need a functioning, stable community pharmacy. I think that's the first key thing in all of this.
Yeah, and if we don't have that, then we will just continue this circular conversation in this room, while the Minister throws it into another set of discussions with a group here or there. And I am not belittling the idea that finance is very, very constrained, etc., etc. I understand that, But if we are to move to a neighbourhood model, that might be the third question. What is the funding for community pharmacy within the neighbourhood model? How is that going to be resourced?
So just to
Because that might actually help community pharmacy as well.
So should
That
we
might be the
ask
three
the Minister, is he going to get in, or should we just say the committee wants you to engage?
Yeah.
So I mean, I would suggest that we write back, say, look, the committee have a number of engagements between officials and the community pharmacy NA, and we are of the opinion that we want you to engage in a negotiation with CPNA the same way that you're currently thankfully doing with regard to GPs, that we also want you to, again, to look at the shortages. We want to know a bit more about funding for neighbourhood model, and then at the bottom we should also say, look, clawback is clearly an issue of concern, and we will be writing to you in again in a short period of time once we have conducted our research paper into that.
I like, Chair, that this has been going on for a decade and more. There's MLAs in this house a decade ago. Rinse and repeat. We're going over the same ground as what we are today.
So are people content that that's the way forward?
Mm-hmm.
Okay, thank you.
Can I ask as well, when is the department back up on this issue?
Not for a while. I mean, we will have the Minister, and so we can ask that, and we will have the Permanent Secretary, but in this...
Schedule that if members wish to in the coming months.
I think we should, given the clash of what was told about the wholesalers in particular, I thought it was very stark that we were being told one thing that clashed quite significantly with what we were told in December. So just the next time that the department are in, I think we have to raise that with them, and I think the research paper that we've requested should help with that as well.
So another thing that I know we're going to be inundated with additional meetings now because of legislation, but there was an offer to meet with Dr. Harrison in relation to the neighbourhood model for an informal discussion. I don't know if that went anywhere.
Chair, just to say members did agree that we're working on it.
Okay, that's okay. So fair enough. That's okay. Right. Okay, members. That we definitely gave that all the attention that it needed there. But unfortunately, it's not put us under pressure for the rest of the meeting. So yeah, I mean, as others have indicated, we all got an email there from the clerk just to inform us that the Minister and the Executive have approved the introduction of a bill to defer hospital parking charges. To defer the Hospital Parking Charges Act due to financial constraints, and staff permits will be free of charge in deferred period. This is going to be coming through accelerated passage. The Minister wants to introduce it on Monday the 9th of March. We obviously want some engagement in advance of that, so we can have officials available if just to have a conversation in relation to the decision and agree to get the reasons for accelerated passage on the record, and then the Minister is happy to brief myself and Danny as Chair and Vice Chair, and he's going to try and schedule that for next week. So when are we saying we can get officials in?
I would suggest, Chair, as soon as
possible. Okay, so we're happy then we try and get officials in as soon as possible, just to have a conversation with that, and then if myself and Danny meet the Minister, then we'll report that back as well.
Just a quick query, do we know how long the deferment's for?
We don't.
As far as I'm aware, Chair, that the bill will be sent into the Assembly at some point in the next couple of days, so I will probably find that out soon, and I can advise members once I have sight of the bill.
I haven't even got a chance to read the email that I've told you that we've just received there, so there you go. Okay, moving on. Item number 8, which is the written briefing from the Department on the Children's Social Care Service Review. It's at page 62 of the main pack. Can I ask if anybody has any comments on it? Go ahead, Linda.
Nearly everything says subject to funding. I would like us to ask the Minister to let us know as soon as, if the 3-year budget is agreed, that how he plans to fund those things, because they've been put on the long finger for long enough. This is, I mean, we've raised this numerous times. you know, people talk about the different Cinderella services of the health service. Children's is absolutely not even Cinderella. It's not even on the ether. I feel like children's services is completely neglected, given no attention. It would be a nice to do. It's not a nice to do. It's absolutely vital. Yeah. So I just would like us, I don't think there's any point in asking right now, but to come back to us whenever, if, as I say, the budget is agreed, and tell us how he plans to fund those measures, because this is too important to let it fall off the edge.
Yeah. Everybody content with that? Colin, were you looking on this? Yep, go ahead.
Yeah, just I'm trying to ask about that because there is funding model in there for new staff, for new sort of family approach, a family support approach, and it's just been delayed. So maybe if we could just ask for some. I mean, the minister said he's going to go to the transformation fund to try and draw down money to implement that. But if we could get an update on where he is with that, and then what will happen with that money and what the timescales are, because Linda's 100% correct. This has just been trailing on for so long.
Yep. Thank you. Next item, number 9, written briefing from the Department, Elective Care Framework Implementation. So that's at page 98 of the main pack. Again, as members, any comments? Dan?
Yeah, just hang on until I get it. So there's a number of things in relation to that I think are strange, actually. One I prepared earlier is really important. So number 1 was the statement that it makes about the funding for waiting lists. That was then 73.5 million. I just cannot find it at the minute. 73.5 million then was taken off to pay for the deficit, because they'd reached their programme for government targets, but not because they'd actually reached the end of the waiting list. So the waiting list the latest waiting list news says that we have 540,000 people waiting on a first-time consultant appointment in Northern Ireland. We have a huge number of people. The Southern Trust gave us the figure of 10,500 people waiting for surgery in Northern Ireland. So we decided to move 73.4 million to the deficit, but because we'd reached our programme for government waiting lists. Now I understand that the deficit is a very, very pressing issue. I do understand that, but I kind of would have liked some reassurance from the Minister that in his new bids, that the money will not then just simply disappear, but it will actually be used for the waiting lists that it was supposed to be in the first place. And I just think that is an extremely strange, given that our waiting lists are so poor, or so bad. I thought that was a kind of a strange one.
You're looking at.
Yeah, Chair, I just agree with Diane there. I mean, I think there is an accounting term for this where you set a target and then just you reach it, that's it, you stop. I mean, imagine the person that was the next on the list after the target was reached and they don't get their appointment. The money was there, but it's taken away simply because the target was reached. And it would suggest that the target may have been set at a very low level so that it could be reached and then it looks good. It feels from that sort of accounting perspective that it wasn't the best way to do things, and certainly wasn't taking into consideration people's health needs. So I think we should maybe just be wise ourselves in the future whenever we see those targets coming in, to maybe interrogate them to see what will happen once those targets are reached, and will more work be done and more people taken off the lists.
Okay, everybody content with that? Okay, so next one, item number 10, written briefing from the Department on the Autism Strategy. Can I refer members to papers at page 102 of the pack? Go ahead, Noel.
Thank you, Chair. I'll be quick. I've put in a lot of written questions on autism services, autism waiting list, and almost all of the answers that we get back produce a negative kind of reaction within me and the organisations, people we are working with, and it seems that not much has moved on. And one of the answers that keeps coming up time and again is about this emotional health and wellbeing framework that was put out to consultation, and the Minister says closed last September, still hasn't reported on, and that this is being like almost as if this will be the panacea to all issues, referral pathways, early interventions for children who either are awaiting diagnosis or post-diagnosis. And yet we still haven't seen this from the department so that we can actually scrutinise it. And my worry is that what we're going to do is have this framework, the final framework out there, that is going to be implemented, but they're going to say that they have no resources to implement it. Meanwhile, people are still struggling and impacting other services. But then also for that actual framework to actually be weak as well and not take into consideration what the organisations and best practice has said, and to have a regional approach too. So I do worry about the time that has gone on, and then when it will be produced, how much into the end of this mandate is there left then for it to be started on by this minister, because we know he's not staying. Is it going to be a priority? And I would just like to, as a committee, for us really to push to get a response to that consultation that closed back in September so that we can scrutinise it.
Okay. Everybody content?
Yep.
Okay, so moving on then to correspondence. So correspondence, item 11 in the pack. So just refer members to correspondence in the main pack from page 119, including correspondence index at page 117. Just can I refer just to a number of items within it. So tab 11.5 is a response from the department regarding the National Autistic Society NI Forgotten Voices campaigner. So I'm just wondering if anybody has any. I'm just highlighting some of the members may have any commentary on. If they have. Okay. Yep. So, I mean, in a similar vein to the kind of points that Dan was raising, there's a response at tab 11.6, page 274, regarding cancer and paediatric waiting lists. So, similar comments. Go ahead, Dan.
No, it's just this is the strangest of all responses that we've had. So, for example, and we talk a lot, and we had a debate the other week or last week, I can't remember when, on data and the importance of data to actually helping us determine outcomes and push forward some. So this is the strangest of responses in relation to that. So we ask for a breakdown of all waiting lists across all tumour sites for clarity, so that we know exactly the number of people who are waiting, and they tell us they do not collect data in that respect or in that way. And they refer us to individual trusts and ask us to go to individual trusts to find out the data. What is, I just don't understand why the Department of Health would not want to know how many people are waiting on pancreatic surgery at any one time, etc., etc. It's just, it is the strangest of responses in relation to some of the issues that are discussed.
So we have an oral briefing on the 23rd of April. Mark Taylor's coming back again to us. So, but I don't disagree with you, Dan. I think in advance of that briefing, the more information that we have to ask the appropriate question, the better. So, I think we could go back.
And I just think that we need to go back. I mean, if the Southern Trust, for example, can tell us that by interrogating their waiting list, they reduced the waiting list by 40%, there is something crazy about the way we manage data and the waiting lists. It's crazy.
This is an issue that you would expect the Minister to be all over, and the Department.
I mean, you really, I think that this is really, really crucial. So, and I'm not saying that clinical interrogation of the waiting lists is wrong, but then when we ask them in this, or I can't remember if it was in this or another question I'd asked, do you collate the data then on the reasons why people leave the waiting lists? Yeah. They don't have that data either, so we don't know whether people leave the waiting lists because they've gone private. We've no idea of this. We just know from this and the previous briefing that, you know, well, it's no longer clinically needed or whatever. I mean, I just think that we have very little coherent information, and we were told that Encompass would provide us with this at the flick of a switch. And I don't understand why we cannot get the information that actually helps us to assess need and then direct services.
All of us will be trying at times to either leave a subscription or unsubscribe to an email, and when you do that, you're always asked asked the reason why.
Yes.
So, like, it seems so bizarre that for something so serious in terms of the kind of information that people aren't asked and that data isn't collated. I mean, I totally agree with you. I think we should go back. Now, both the trusts that were asked about that said that they were following standard procedures, so I think it might be a case of us saying that we think that standard procedures should include collating this type of information, because it's going to be extremely useful moving forward.
Sure, I'll be brief. One of the issues I think is more like needs more of a focus on, and it really concerns me, is that there's no data or evidence as to the effect on a late diagnosis.
Yes, that's in this as well.
And
yes.
actually, like, the reason why we don't get that, I think, is because that can be potentially quite serious, and we all know that it will be sometimes it's an SAI. That's private, so that's never going to be reported to a statutory committee unless someone comes to us saying I'm not happy. But if we don't have that evidence, then how can if we don't have it, if the department doesn't have it, and if the trusts don't have it, then how can we change the system? How can we actually fix something that is broken if we don't have the evidence to say this is what the effect is because of it? I mean, we see it on the news, so we know, but that's anecdotal evidence, and I think that was a concern from me there, is what's the learning process, like almost the patient audit, not in like the audit going to the patient itself, but like what's the auditing process of these late diagnoses? And I don't know how we can incorporate that as a committee into getting answers, because what we fundamentally want is for there not to be a late diagnosis.
So how do we incorporate that?
Yeah, I'm wondering in the first instance.
I'm sure there is general data that, you know, and I think that Cancer Research provided that in its last report to us about the impact of waiting so many weeks, etc. And I just...
So rather than reinvent the wheel, does the department use that from the third sector, or community and voluntary sector? Does it use their research?
Well, we should just ask the department what data they use and what they can provide us. So I mean, I think we should go back. The more information, as I say, and more of these questions we have, the more useful our briefing session on the 23rd of April will be. Okay, just a couple of other things to flag. So at 11.13, there's correspondence from the department in relation to gambling and related harms. A policy support paper should declare I'm chair of the all-party group in this issue. I mean, it's clear there's an awful lot of harm, and I mean the APG, and Danny will know this as well, it has been engaging with both departments for health and the communities, because there's a levy. I mean, the Westminster government have a levy on online gambling that we currently are not benefiting from, despite the fact that obviously gamblers here are gambling on these companies. So we are trying to ensure that we can use some of this evidence to get our fair share. I mean, I think we've kind of calculated that it could be worth over 2 million to the north. So I mean, I think this is useful moving forward in relation to that we just need to keep the pressure on. I mean, we have so many needs here in the north from a health perspective, and gambling addiction is obviously a key one. If we can get 2 million from Westminster as a consequence of that levy, then we should be doing all we can to get it. And then one other thing, just for myself, there's a muscular dystrophy and the spinal muscular atrophy. I mean, we're seeking to we're seeking the committee's urgent support for adding, obviously, the spinal muscular atrophy to the newborn screening programme, and they've offered a brief. So we've offered them a briefing at the next informal session. Okay, and anybody any other points that they want to make? Yeah. Go ahead, Danny.
Yeah, Chair, just the letter from the Executive Office at 11.19, just that the minimum unit pricing hasn't got on the executive agenda yet, and just to be note disappointment that this will be a massive missed opportunity, that if we don't get this through in Northern Ireland, this legislation, it will save lives and reduce pressure on the health service. And it's something that we should be looking seriously at. I know I've been lobbied by Northern Ireland Drug and Alcohol Alliance and the Non-Communicable Disease Alliance for Northern Ireland, which is a huge body of charitable organisations and health organisations that back this and are pushing this very strongly. So I'd be very, very keen that, you know, that this comes. I think we have a big opportunity here.
Yeah, and I think that was the view of the committee, which is why we wrote to the executive office in the first place. Just to remind me, if that isn't the case, the minister comes and makes a statement when?
I think from memory it was before the 6th of April.
Okay.
So also I presume it would have to be some point in March with Easter recess at that period.
Okay. Anybody any other comments? Okay. Are people content with the suggested actions from the correspondence index, page 117?
Yes.
Okay. Forward work programme, refer members to the draft forward work programme, page 482. Everybody content with it?
Yes.
Just to remind everybody, an email was sent with an invite to go on a joint visit with the Permanent Secretary to St Francis.
Hasn't been sent yet.
There's an email going to be sent, a joint visit with the Permanent Secretary for St Francis Hospital in Dublin, Wednesday the 5th of May. So if everybody could respond to that.
Thanks for saying it wasn't sent, because I was going to sit here and say, yeah, I've seen it. I don't remember saying
You're
that.
going to get caught out. AOB, any other business?
Yes. Chair, I just wanted to raise, I've heard of being communicated about a meeting that took place, an event took place in Parliament Buildings on Monday about eating disorders. And I've been asked if MLAs were invited to it. Now it looks as if it was a departmental event and there was people with specific lived experience of eating disorders who were presenting on it. I don't think I was invited, and I'm just wondering if any other members of the health committee or MLAs particularly were invited. I think
Where was it,
MLA
Donny?
attendance, eating disorder,
Where was the event?
Parliament Long Gallery on
In the
Monday.
Long
Gallery
Gallery.
on Monday. Yeah. Although you will have your opportunity to have your say on it in the debate this week.
I think it's just a fair point, because no MLAs were invited and they were there, and these service users with lived experience were speaking.
I understand it was quite a disappointment for people who had lived experience who were
I
coming
would
to
say
address
so,
MLAs, and there was no MLAs there.
Okay, we should ask about that. I've put it onto my search engine and I have it's not there. So
The committee didn't receive any
okay.
invite.
So we should write to. It was the department organised the event.
Yeah.
Okay, so we should write and ask in relation to that. Go ahead, Linda.
I'm going to say, and this might be how it was missed, it was actually done by the APG, from what I can see in this email. So it probably looks like it was an APG meeting if you didn't read on through it to see that there actually was something planned, but it didn't give the detail then of where it was or what time. It just said they were hoping to have an event on Monday the 23rd, but no detail. So the actual detail of the event then wasn't followed up to.
Maybe we should just get started then between the APC.
Can I just say, this was the launch of the Eating Disorder Managed Care Network's strategic framework and 3-year implementation plan. So,
Then no, separate thing.
Yeah.
Fair enough, sorry.
And it has the department's logo on it, and
Okay.
So it did very much look like that.
We can investigate that.
Thank you.
Thank you, Danny. Okay, members, I'm going to seek agreement that we move into closed session just to do the deliberations on the adult protection bill.
Great.
Okay. There you go. We're in closed session.